Good morning, and good morning everybody. Welcome to this meeting of Adults and Community Wellbeing Scrutiny Committee. Before we begin, there is no fire drill planned this morning. In the event of the fire alarm sounding, please leave the council chamber through the rear doors and assemble in the car park and await further instructions. I welcome Councillor Liz Sneath here for Executive Support Councillor for Adult Care and Public Health. Welcome, Liz. Apologies from Wendy Bokit, and also welcome Martin Samuels, Executive Director of Adult Care and Community Wellbeing. Other participants will be introduced when we reach their item or when they speak. The meeting is streamed in the usual way, so on that note, we will start off with apologies, please.
Thank you, Chairman. Yeah, we've received apologies from Councillor Young, and we have Councillor Bowles here as his replacement member today. Thank you.
So, welcome, Councillor Bowles. Nice to see you. Declarations of members' interests. If any member has an additional interest throughout the agenda, please let us know. On that, we'll go to the minutes of the 17th of January 2024. To confirm as a correct record the minutes of the meeting on the 17th of January 2024. The minutes are found on pages 5 to 11 of the agenda pack. Are we in favour of the minutes? A proposer, Councillor Tracy Carter, seconded. Councillor Rob Kendrick. Can I confirm that you support the minutes? All those in favour? Any against? Any absentees? 2. Thank you. Announcements and update by the Chairman, Executive Councillors and Executive Director. The one from me is owing to commitments of some of our presentations at other meetings, there have been changes in the order of agenda. So we will take item 8, Integrated Lifestyle Service Contract Extension, as our first main item of business. Then we will take our 3 remaining items of business in the order listing, the introduction to the carer service, followed by residential care and residential with nursing care, usual costs, and then finally the service performance for quarter 3. One other question that I've actually got is, when does Glenn go? As in his official retirement date. Just because actually I don't know whether we will. It could be, I have a feeling it's at the end of March, the official, and I'm just thinking that the committee really hasn't perhaps had a chance to say farewell and thank you for all your work, and it'd be quite nice to do that, but I don't know if you can shed any light on that, Martin.
It's during the course of April, so I think he will be with the council for at least part of April. But I don't think it's. I'm not sure if he's staying right until the end of April. He's. I mean, as you'll be aware, he's effectively currently focused on special projects and providing support to other councils around the country based on our experience here with the CQC. So he's not sort of here very much.
Yeah.
But I think he actually formally leaves the council during the course of April.
Okay. Well, if we could just perhaps see if he's about, that he can pop in at the next one just to say farewell and. I think would be quite nice for the committee. So we'll see what happens on that one. So thank you. Liz, I believe you got an announcement.
Thank you, Councillor Marvley. Yes, unfortunately, Councillor Bokit's unable to be with us this morning, but she'd like me to thank our team for all their hard work over the weekend, helping with the junior doctor strike. She says they've really excelled. So if that could be recorded, please. Thank you very much.
Excellent, thank you. Martin, have you got anything?
And I think really just to pick up that point that obviously the health system, I mean nationally, it's a national issue rather than a Lincolnshire issue, is under significant pressure. I think the fact that we haven't been seeing really difficult positions in Lincolnshire is obviously a credit to all of the NHS staff who are working through this. But I think it's, I'd absolutely echo the comment that's just been made about the very, very effective work by staff across adult social care to make sure that our bit is running as smoothly as it possibly can, and that therefore people are receiving as good a service as they can, and therefore the negative impact on them is minimised.
Excellent, thank you. Thank you for that. Okay, so we'll move on to the first item then, Integrated Lifestyle Service Contract Extension. And for this, I'd welcome Derek Ward, Director of Public Health, Andy Fox, Consultant in Public Health, and Rachel West, Senior Strategic Contract Manager, Commercial Services. So welcome all three of you. I believe Andy's going to start off. So thank you.
Thank you very much, Chairman. Good to be here to talk through this report asking for scrutiny of a paper going to executive to ask for a 12-month extension to the Integrated Lifestyle Service. And this is our Lincolnshire's primary health improvement and prevention service. And I think it's well known, well said that prevention is better than cure. And the Integrated Lifestyle Service has really been I think a real success for Lincolnshire in demonstrating the impact and effectiveness of an integrated approach. I heard some noise there. I don't know if that was coming through. I will keep going unless someone tells me different. An integrated approach to addressing these key lifestyle issues which actually contribute the vast majority of ill health and mortality in Lincolnshire. So if I just talk you through, so that's what we're here for. I'll just talk you through a brief summary of the paper that you've got in front of you in your notes. So as you can see, the original Integrated Lifestyle Service contract was running from 2019. It does finish in July 2024. We're looking for that extension for a year at that value of total sort of 3.2 million, broken down into the component parts you can see in your report, in order really to allow us to do a full recommissioning programme at this point that hopefully allows us to consider the changing landscape of prevention and health improvement in Lincolnshire. And colleagues will be aware of the integrated care system. And this is a service which is jointly funded by the Integrated Care Board. They put £500,000 in per annum. And obviously Lincolnshire County Council contributes the rest from the Public Health Ring Fence grant. But as the NHS England and local focus increases on addressing health inequalities and preventing ill health, which obviously has that effect of reducing demand on the overall health and care system, with the impact of some key reports, the Hewitt report recommending that the NHS increases its spending in prevention, we are hoping to be able to recommission a service, and one of the options we'll be looking at is an increased service budget, increased outcomes, with hopefully some opportunity for NHS to have an increased investment in prevention. So that's the context. And that's why we were looking to get this extension now to enable us to do that. Just to highlight really that there's a few other aspects to consider. One of those obviously is that the government have made some additional announcements around some of the key areas here. I want to just highlight at the start the smoke-free generation plan that the national government have announced. As you'll be aware, smoking is one of the key risk factors, in fact the single biggest contributor to health inequalities in life expectancy. And the government have announced a plan that will significantly increase the funding available in Lincolnshire for addressing smoking, providing that we protect current spend. So it's about 1.076 million of additional funding per annum the government have announced and have timetabled for the next few years. We do need to protect our current spend on smoking cessation in order to access that funding. So I mention that again for context. And if I briefly talk through where we are with the service, and as I say, it started in 2019. It focuses on 4 key lifestyle risk areas for health, and those are smoking, obesity and overweight, and alcohol use and physical activity. So the programme was originally designed really to focus on people with a long-term condition, But obviously, starting in 2019, we had COVID coming very, very fast, which of course changed the entire delivery profile of the service. Suddenly everything had to be remote. And also it changed that sort of interaction with the health system, which was no longer focusing so much on sort of health improvement. It was obviously all hands to the pump to manage COVID. So we shifted to a self-referral option as well. That was added in. And actually, since then, really the service has grown, has gone from strength to strength, really, I would say, and is starting to demonstrate performance, well, is demonstrating performance that actually outstrips national benchmarks in each of those key 4 areas, and is now actually hitting its overall targets for volume as well. So it's a service that is considered to be high performing. We have had this evaluation, which is included in the papers, from the University of Lincoln, independent evaluation, which again demonstrated that it is outperforming national benchmarks in each of these key 4 areas. And additionally is also seeing a positive impact in health inequalities. People may be aware that these kind of preventative services, one of the risks of them is that they're often used more by the worried well, or people who have plenty of access to things and time to spend on their own health and well-being. So often these services can unintentionally increase some of the inequalities that we see in health outcomes. I'm really pleased to say that the evidence that we've got suggests that One U Lincolnshire, as is the brand that the provider Thrive Tribe use, actually sees more people from that bottom sort of 30% of the population in terms of deprivation, socioeconomic deprivation, than you would expect. So it's actually overrepresented. More than about 38% of their client group come from that bottom 30%. Now that's evidence that we can actually say this service is having a positive impact on health inequalities. So not many health improvement services can actually say that. So really pleased with that. You've got some tables in your report which show you some of the metrics in terms of the total outcomes we've got so far, and indeed the increases since 2019. And you can see that actually some of the aspects like weight management, has increased by 700% since the program started in that first year. Physical inactivity outcomes have increased by over 500%. So there's been this clear profile of the service really getting embedded in the wider health and care system. And I'm really pleased that actually we speak to doctors and colleagues in the ICB, in the different health trusts, and often we get public health, get trainee doctors to come and work with us as registrars, and we always ask them, have you heard of One U Lincolnshire? Do you use One U Lincolnshire? And they often say, oh yeah, absolutely, I'm referring to One U Lincolnshire all the time. It is becoming embedded in the health and care system as part of the key sort of prevention aspects that we have. So as I begin to bring this to a close, you'll see again tables that we're actually demonstrate we're outperforming the national average, and in smoking, weight management, physical inactivity, and alcohol reduction targets, and those have increased year on year as we've got through. So it's a service that is doing well. It's in a strong position, and my sort of final point is that we have added some discrete components on, which you can see are included in that table and are costed there for the additional 12 months. And these are a child and family weight management program, which started in July 22, and a strength and balance falls prevention service, which started in July 23. And also there's an employee challenge service, which is used for NHS and Lincolnshire County Council staff to help our staff get healthy and well. And all of those services are, they're showing promising signs. Obviously, they're quite early in the delivery cycle, but we are seeing positive outcomes from those, and we certainly want to keep those going for the additional run of this contract extension in order to continue to investigate those models, demonstrate the effectiveness or ineffectiveness very clearly, so that when we recommission, we can actually include that in the scope for the recommissioning and decide whether those are services that we want to mainstream and include as part of a new model, or whether they're actually not cost effective for Lincolnshire and that we don't want to include them. So important that we continue with those from our perspective, which are starting to show some good evidence. And just to highlight, we often talk about in the public health world that the intransigent problems with children being overweight and being at unhealthy weight Our Child and Family Weight Management Programme, which takes referrals from the National Child Management Programme, has seen 73% of children on that course actually reduce their body mass index, their BMI. So again, that's not something that many health improvement services that target children's weight can say. So whether or not those figures are borne out when we get more data, we'll have to wait and see, but early indication that they're working well. So that's where we are, that's the case, and obviously we'd be really happy to answer any questions. I don't know, Rachel, did you want to add anything from a commercial perspective?
Thanks, Andy. Just to say from a commercial perspective, this provider is a real key strategic partner, is delivering well. There are no concerns around their performance to prevent us, recommending and bolstering that extension period to allow, like Andy said, that recommissioning programme, which has already commenced, to really understand and bear fruit from those additional elements that are noted in the paper. So no commercial concerns around extending.
Thank you, Chairman.
Thank you. Thank you. This is going to the executive, so we need to put forward any suggestions to the executive. That's the basis of this agenda item. But also here, because it's a short one-year contract in effect, there is the chance to influence the following contract, which will be drawn up, and so any fantastic great ideas that this committee comes up with, and usually does, therefore I would feel that we can put those ideas forward, and the officers will certainly investigate. So on that note, I will open it up. Andrew?
Yes, thank you, Hugo. I've just one question on the tables on page 53 and the outcomes for each of the 4 different areas of work. I'm assuming, and this is an assumption, that some people are on more than one of these programmes, because if they're smoking, they've probably also got one of the other issues to deal with. So have we any figures on how many duplications there are in these figures? Because that would be helpful. How many actual people are involved altogether? Thank you.
Thank you, Councillor. A really good question, actually, and we have some figures on that. Important to say that actually the way we ask for the provider to report to us is by outcomes, but we do have some data on that. Certainly the evaluation that the University of Lincoln conducted found that of 24,370 referrals they looked at, there were 16,354 clients. So that's roughly a third of people were on more than one. And that's actually where we get a lot of the benefit from, as you can see from the report, in terms of people who maybe came for one issue, finding that we've helped them with another. But I think Rachel has some more data.
Yeah, thanks, Andy. So yeah, we do have some data that we can share with the committee, and I think understanding from the provider's perspective, like Andy said, we do record on outcome-based rather than individuals, but we have got some data in terms of how many people start on those programmes, and we can investigate with the provider how many of those ones. I would say it's not duplication as such, it's actually that's the way that the service is designed to work, and the evidence is actually showing that that's where we get the most benefit from, where people are engaged maybe on more than one programme at a time. And for some individuals, we know that it's not necessarily sequential. Some people, it does make sense for them to be on 2 pathways at the same time, but it is down to the individual and how they work with them. So we know around, certainly the last financial year, the last contract year, contract year 4, there was around 4,500 individuals working and starting those programmes across weight management, smoking and physical activity. It's a bit lower for the alcohol pathway. We know with the alcohol pathway, the vast majority of those outcomes do come from those other 3 groups. So a lot of those alcohol interventions are absolutely done as a secondary conversation that's brought in while they're managing their smoking or their, their weight management or their activity basis. So we know that, but we can certainly get some more data for the committee if they would like. But we'd ask that from the provider in terms of that analysis of the individuals, because it's not currently how they report it to us, but they work with us really closely. If we can ask them for that, I'm sure they would.
Yeah, thank you. That's what you said is what I assumed, and I didn't mean it as a criticism. It's a good thing if people are getting help with these other issues. So thank you. Great, thank you.
Thank you. Derek, did you want to come in?
Yeah, just to reiterate what Rachel just said, we set the service up specifically to focus on people. Now, we need to count interventions because we've got to demonstrate value for taxpayer money, of course we have, but these are individuals who have particular issues often, and the evidence would support this, that somebody who wants to quit smoking might already be overweight and they're worried about through quitting smoking they're going to put more weight on, so they might get referred into the service because it's a universally available service for anybody who smokes, but that individual might actually start by trying to lose some weight. That then they get that support. The fact that they do lose weight then gives them confidence to try and quit smoking, and we see higher quit rates than we would see otherwise because of that confidence. So it's a reinforcing psychological model, and actually the whole model is predicated on psychology and motivational interviewing and some of the key aspects. So we treat the person, we support the individual, and the outcomes are great, and we need to measure the outcomes, but it's about the outcome for the person at the end of the day.
Excellent, thank you. Councillor Tracy Carter.
Thank you, Chairman. I'm a big supporter of 1U and what they do, actually, and I think that multi-problem is really important. Again, I would support the extension for another year. For the new contract, I would love to see that we do keep that self-referral element in. I think that's so important that people can actually get kind of into the system themselves rather than going via the GP. One of the challenges I think with that is I've tried recently to get in touch with them because I was challenging that not enough was being delivered by 1U in South Holland. So I wanted to speak to them about that. And I used the normal channel, the going through the telephone number, not kind of a contact out there via the council. And actually I tried 4 times and got no answer, got answer phones and that kind of thing. And I didn't get a call back from that. In the end, I went the email route. So I want people to be able to self-refer in, but they need to get that response there. So certainly that would be a really important thing for me. The only thing I think really I would possibly challenge is the employee challenge, 58 grand on that, when it's limited to NHS and council staff. Is that right? Does that sit with me? It doesn't sit with me, I'll be honest with you. And actually, if it's for something like the Heart and Soul programme that they do, which is a great programme, and we all got that email, so hence I know about that, but actually why not open it wider to employers but take away the starter pack? So they could reduce the cost down from not delivering that starter pack, but still doing that email campaign and things like that. So I would question if that's always the best spend for that section. Thank you.
Derek?
I understand the challenge. I think I would argue that our staff are our biggest asset. And we know that the majority of sickness absence is down to one of 3 things: either musculoskeletal conditions, bad backs, bad necks, relatively low-level mental health issues, so depression, anxiety, or viruses. All of those things will be tackled by increasing physical activity, losing some weight. Obviously, quitting smoking is great for everything. So supporting our staff, I think that £58,000 is fabulous value for money. And if you look at all of the blue chip private companies, they have a far wider and deeper employee staff wellbeing offer. We've come a long way over the past 5 years, I think, within the council and broadening that out. So I think I challenge back. I think we need to do more to support our staff and make sure we get that universal access. If you think about a reduction in sickness absence of 2 or 3% across the council, it will blow that investment out of the water in terms of the cost. Key problem, as we frequently talk here, is trying to demonstrate that because we supported our staff through this sort of programme, we reduced sickness absence by X%, because you can't draw that line. But I guess from my perspective as a DPH, the evidence is legion that having a well-rounded support package for employees is really important. It makes them feel valued as well from a recruitment and retention and sickness absence rate. It's a cost-effective, in fact, a cost-returning argument.
Well, I would just agree with, in some sense, of what Tracy said, that but I do feel that some of our staff and the NHS staff do not necessarily reflect the image of a healthy lifestyle, and often they're the ones promoting it to other people, which doesn't sort of looks good. They do have the advantage that there's normally always 1U Lincolnshire has its little stall set up somewhere, and they have a much greater advantage than most of the other people, because actually there's generally we do promote it quite well. I think we promote it well. There is a blocker in the lack of uptake by some people, and that's something I think, unless you ask directly the question, why don't you necessarily join, which I know then vindicates them that you've actually put them into that category, but then if we don't understand sometimes the thinking behind what they're thinking, how do we solve the problem? But anyway, Tracy.
I would challenge back and say those blue chip companies, they're paying with their own money that they've earned. We're paying with taxpayers' money. So yes, I would challenge that it could be measured, that you know, sickness saved and things like that back, but actually we haven't got that measure. And I still feel that it's using the pot to ensure, and absolutely it's a lovely thing, and there's no part of me that's saying that staff shouldn't be looked after, but actually there's a lot of employers out there that would like to offer additional benefits to their staff but are not in the financial position to be able to do so, and would love to have this kind of thing. If we made the cost less by not doing the starter packs, I mean, some of the starter packs that they're sending out to the employees have got skipping ropes in them and things like that. Could it not be looked at still to reduce the cost of those starter packs, so therefore there isn't a starter pack, reduce that cost, and those emails of those training sessions and all of that could go to a wider person still? Thank you.
I'll answer that one. We will put that in the recommendations, I think, to go back to the executive, because at the end of the day, we run business Lincolnshire website, and there's no reason why we can't, or as in One New Lincolnshire can't be promoted through that service to employers. And I think it's something that perhaps wants looking at more to do better. But Derek?
Yeah, I think in terms of the 1 year extension, obviously there's a challenge there about trying to churn. So if Scrutiny are comfortable that we don't include that for the 1 year extension, very happy to come back and have a conversation as we start to develop the service specification for the new service, and maybe get into that particular aspect in more detail. So my suggestion would be not to include it in this recommendation, because this is about the 12-month extension, but then we will, of course, come back to Scrutiny with a new service development. I suspect Councillor Bowkett would have a view as well on this. I don't know whether Councillor Sneath does, but it's probably a conversation as we go into the new contract, if Scrutiny are comfortable with that one rather than for the extension.
Okay, that's great. I'll move on then. Councillor Rob Kendrick.
Thanks, Chairman. I apologise if I've actually missed it in the report, but my question is about the referral process, particularly in relation to the child obesity programme. Do schools play a role in this? If you can confirm that, that'd be great. Thanks very much.
Absolutely. So yes, indeed, and a great question again to understand the mechanisms here. There are actually two pathways that we have. There's what we call a healthy weight pathway and healthy lifestyle pathway, and the referrals come primarily from the National Child Measurement Programme, which, as you'll know, is conducted in schools. And so children in reception year 6 are measured for their weight, and their BMI is calculated. And every single one of those now, we're working very closely with the team, the 0 to 19 Children's Health Service that administer that, and our provider, Thrive Tribe, will have the ability to contact and offer a brief intervention over the phone and a discussion, supportive chat to the parents of every child who is measured over the threshold in the National Child Measurement Programme, which is a fairly significant investment in time. And obviously, any children that are interested can then take up the offer. The other pathway, the healthy lifestyle pathway, it was very important, especially to me as I was designing this service, that we didn't unintentionally exclude kids who would really benefit from this intervention, who just happened to be a little bit the wrong side of a particular cut-off point. So I wanted to make sure that schools in particular could refer children to this programme, because it's going to be great fun for them, really beneficial for the parents, who had, as they deemed it, capacity to benefit. So we added this whole healthy lifestyle element in, where children who weren't over the BMI cutoff could still be referred in by schools in particular. And so we're working with specific schools to deliver that. And Thrive Tribe have been really trying to get sort of interest and engagement from specific schools, primary schools, to increase the uptake of that, because that is actually quite innovative. There's not many child family weight management programs that have that element in. They're normally very closely measured on BMI and targeted. And yeah, my concern was that we could be missing out on some kids that could really benefit, and it's the schools that know. So yeah, absolutely, that is part of the referral mechanism. Thank you.
Just on that, you mentioned that there's 2 pathways, and the fact that we're looking at the complete picture of this service and a whole overview and everything else. In some sense, could it fall under the wellbeing branding? I know this is bedded into the system within our referral colleagues, but 2 pathways sounds like it's already getting a bit more complicated than one. You know, technically, in the overall picture, are you looking at streamlining some of these sort of, it's one pathway really, isn't it? It's called a better life, well-being.
No, it's a very good point, actually. And I suppose what I would say is that actually the child and family weight management, and indeed the Falls element, are they're pilots to try something and see what issues that we find. And actually, we're learning all the time as we do these things. They are deliberately innovative because, as you'll know, Lincolnshire is different to many other counties. Lots of the evidence on this stuff comes from cities where it's very different delivery landscape. So if we want to do something right for the people of Lincolnshire, we often have to try and get out there on the cutting edge and try something. So the child and family weight management is innovative. The FAME, the Falls exercise program to prevent falls is very evidence-based. So that's we'll be more confident in that. So yeah, I think there is scope as we move towards the next contract for actually considering, can we rationalise this? Does it make sense to people when they're coming in? And I think it's a good recommendation that we look at trying to keep things simple and understandable for the people of Lincolnshire, because we don't want to overcomplicate it. So it's a really good point.
Okay, Derek?
Yeah, absolutely agree with everything Andy's just said, and certainly something we want to build into the recommissioning process. Generally, the referral pathway is quite straightforward. Either if you self-refer, if you meet the criteria, or you are referred by somebody else. It's always going to have an element of targeted work, because if we don't do that, we do one of 2 things. We have a universal offer, and we don't know just how much will be taken up, and therefore what the overall cost will be, and whether it's appropriate, or equally we target everything and then we haven't got a universal offer, which certainly when we brought this in the first instance through scrutiny, it was really important to have a universal offer for the people of Lincolnshire. So there's always going to be a bit of a balance, but the challenge to try to minimise the complexity is absolutely a fair one, and we will. But we do want to also target individuals if we're going to meet the council's statutory responsibility to tackle health inequalities. So there's always going to be a bit of a nuance there, I think.
Okay, thank you. I've got Councillor Karen Lee.
Thank you, Chair. Yeah, I'm supportive of this. I mean, from the very inception of the NHS, it was always meant to be about prevention prevention initially of illness, curing it to start with, tackling what there was, and then getting on with preventing it. But that went well, didn't it? So very supportive, and I think page 53 gives the rationale. It was an independent evaluation about the performance. So I'm happy with that. Just to say, I was a bit confused because one of the tables on page 53 has got numbers and the others has got percentages. Can we have numbers and percentages on all of them? And can I have those emailed to me? Just, I find it easier to look at things at numbers, but I get the value of percentages as well. But going forward in all of the reports, can we have numbers and percentages? That was my first point. I totally agree with Derek's point about the 58k for the staff, for all the reasons that you said. And I think it is important that we lead by example and that we support staff and everything. So I'd agree with that. I mean, I'd agree with widening it. If LCC are prepared to put some extra money into making it available for everyone, great, let's do it. But we'll see if that happens. Hopefully it will. I'm sorry, I have to say, Chair, that I did take issue somewhat with your comment about the image of NHS staff. It was a bit of a blanket statement, the image of NHS staff, without any evidence or rationale for that. I think actually the NHS staff don't have a particular image, and lots of them work really hard.
They don't have an image, but there are some that perhaps could benefit from some of the services here. And I'm not saying that's branding everybody, but there's one thing for sure I can see with my eyes, and I've been to see, and sometimes you do meet people that are saying, get healthier, and you think, well, actually, also, perhaps look at that yourself.
Well, thank
And
you for interrupting
if we
me,
can't
but actually,
raise that,
thank you for interrupting me, but you haven't actually given any evidence of that, and I think it's a bit of a personal, and some NHS staff might find that a little offensive, because, as I say, you haven't given any
obesity
evidence of that, and
represents
you're
one of the
interrupting me
largest
again.
issues in the county. So,
Well, thank you, but as I say, it would be nice if I could finish before you interrupted me. But yeah, I support this. I think it's a really good, it's a good study, it's a good scheme, and yes, I'm absolutely behind it. And if we can put some extra money into widening it so lots more people can have it, then I'd absolutely be behind that. Thank you.
thank you. Okay, Councillor Mark Whittington, please.
Yeah, thank you, Mr. Chairman. I'm looking at, when I can call it up, the table, I think, on page, the flow diagram on page 84, which sort of gives the client pathway through. Obviously, yeah, you can see on there the, the sort of referrals sort of through GP or primary, secondary care, and what's everyone for self-referral. And I notice third down, there seems to be almost sort of in the pathway that if you self-refer, because you've got the motivation to change, you kind of go quite easily down the pathway. But if you've been referred by a GP or another source, and they're not motivated to change, you've got this sort of two-way arrow. So I'm guessing. I mean, I can understand why that's there, because if people are motivated to change, there's going to be an issue. But I'm just wondering that, and I think the point again is, in all the stats, do you know, are you able to split out the difference in terms of how the individual was referred? Because this would indicate that if you've self-referred, you're more motivated to change, therefore you've probably got a better chance of achieving the outcomes. Whereas if you've come in from the other route and you potentially might not be motivated to change, or you might be a bit reluctant to do it. You know, you either say, "Oh, I'm not doing it," or "I'll do it," but your heart's not really there in it. I'm just wondering if you're able to split out the numbers and the percentages, because I think that might be quite useful to actually see that actually those people who do refer in are you know, just so we can see this, because I think that'd be really, really useful to actually understand that. Thanks.
I'll start with the answer, and then I'll pass over to Andy and Rachel. I think the way that diagram's drawn is probably, and I completely understand why you're reading it the way you are. I don't think that's how the model is developed. It's either there is a clinical referral or there is a self-referral into the service, at which point there is an assessment. Is this individual motivated to change? And it comes back to that point about the psychological underpinnings of the delivery model is motivational interviewing. If that individual is deemed not to be yet ready to change, then regardless of the referral pathway in, then they don't progress, and there's further conversations to try to get that motivation going. So I can see why you're reading it that way, but I don't actually think that's the way it's running in practice. It's one integrated assessment, regardless of what your pathway in or out is. In terms of the numbers, I think it's a really good question about, if you are referred by a clinician, are we getting a higher number of people going on because they are motivated to change, as compared to if you self-refer? I think that's a good question, and I saw Rachel nodding her head, so I think she's got the numbers.
I haven't got them with me today, but I think we've got a few requests to come back with some of that data, so I'll certainly add that in. I think what I would add in terms of the self-referral pathway, I think it's really important to remember why that was established, because it wasn't originally in the contract. The self-referral pathway was put in because of COVID, and during COVID, obviously, the service wasn't able to receive referrals from health professionals given the situation. We monitored that really carefully as we came out of COVID to make sure that that referral pathway, where it was a self-referral, was still the right thing for the service, to make sure we monitored really carefully how many of those individuals that are coming through from a self-referral mechanism do also have a long-term condition. So actually would have been referred by a clinician and it would have been eligible through that pathway, so that it wasn't just a self-referral pathway that would be open to all, let's say, that we were making sure it was those individuals who also had a long-term condition. I think as part of the recommissioning, that understanding, that analysis of those individuals who have come through from the different pathways and other outcomes different, I think is part of the analysis we will need to do to look at that comment that Councillor Carter made about the future of a self-referral pathway in the new model as part of our recommissioning exercise. But certainly as part of the additional bits of data that have been requested this morning, I will add in what that current figure is for self-referrals, but it is monitored really closely to make sure, and we know it is a high percentage, I think it's around in the 70s%, also have a long-term condition that come through that pathway. But obviously self-referral pathway for smoking is always been the case. It's just for those other pathways that there's that self-referral that is still there at the moment.
Andy?
Thank you. Yeah, and again, just to add a point there, really, that the self-referrals are actually a route that in some senses are more likely to have that motivation to change, but it's not going to be a binary thing. And actually one of the strengths of the model is this health coaching approach, because people will sometimes have a degree of motivation to change, and they'll have had that discussion with the GP or the referring professional and said, oh, go on then, I suppose I could look at losing a bit of weight. Yeah, I know. And actually their motivation is probably down here, but there is some. So just to say that chart's definitely an oversimplification, because the strength of the health coaching approach is that they will have a conversation, a supportive chat, and they'll say, oh, you know, what are you looking to change? Well, the doctor says I could probably lose a few pounds or quit the cigarettes. And they'll work with them to actually explore that and to not be aggressive and say, well, you're not motivated enough, you're out the door. So actually, you know, just to say that model is definitely an oversimplification. The health coaches actually will consider that. And as Derek said earlier, they'll treat the person rather than just follow a protocol.
Just on that, because basically there's a couple of things. In essence, I mean, let's not beat around the bush here. If you want to get healthy, it's hard work, and it's no mean feat, and losing weight is hard work. It's not easy, and there is a sense of, and that's why it's not for everyone. But what you've in effect said, that it's fine if you're self-referring because you're gearing up your own mentality to take on board a task, and it is a big task. And in effect, what Mark said and what you've also said is that there is a sense of, if it's done clinically, is there a sort of like an initial entrance of like counselling to actually get the mindset right? Because I think, you know, it is a challenge. You know, you're talking about a years long process if you want to really start and turn your game around. And I would say, is that part of it and something that we can look at? Or?
No, absolutely it is, through this technique of motivational interviewing, which is something that the health coaches will be trained in. And for exactly that issue and the point that Councillor Whittington raised, essentially motivation is going to be a tricky one, and people have got a hard task ahead. You know, if they're going to lose weight, they're going to need to change their lifestyle. Changing a lifestyle in a world that makes it really easy to have an unhealthy lifestyle is always going to be challenging. So that motivational interviewing is an evidence-based technique they use to actually essentially counsel and coach the person through what's going to work for them, what the easiest wins they can find in their lifestyle are, and maybe give them that additional support when they are really up against it. So, yeah, really important part of the model.
Okay, Martin?
Yeah, if I can just step in there. I think I'm really encouraged by the fact we're having this conversation about motivation, and I think it really underlines the importance that in these lifestyle issues, it is people change their own lifestyle. You can't change somebody else's lifestyle, and it's very important, therefore, that we have an approach which is fundamentally people doing something for themselves with our support, as opposed to us trying to step in and do something to them. And so, therefore, the focus on motivation at the start of the process is absolutely fundamental, both because it means that we get people to be in the place where actually there is a chance that they will be able to make a difference, and therefore we're not trying to do things to them which could potentially turn them off and make it harder for them to change. I think it also means that we're able to make better use of limited public resources. So in a previous area I worked, we had a very large number of people being referred into a quit smoking program, and we were laying on a very large number of clinics to work with those people, and then finding that those clinics were sort of half to two-thirds empty because we hadn't addressed the issue of motivation, that people, in a sense, you know, as has been described, were having a conversation with the GP saying, well, all right, maybe I should give up. They were being referred, but they never turned up, or they went to the first one because they didn't have the motivation. So we'd spent a very large amount of money putting on a very large number of clinics that actually we could have met all of the need with a third of the number of clinics and had that funding available for more effective work. And indeed, it would have been more effective if we'd spent the money on the motivation. So getting the motivation right at the start is going to be much better for the individual, but also will allow us to make much better use, get much better value for money for the public pound.
Excellent, thank you. Did you want to come in, Derek, again?
It was just coming back to Councillor Whittington's, the diagram. You'll see throughout the diagram psychological terms. So it isn't just through and I know this is recognised, it's not just through the assessment, it's through all the interventions as well, and different models. So sometimes it's coaching, peer support is really important in some areas, one-to-one. Equally, telephone consultations and support. We try to tailor the support depending on the individual, and it comes back to that supporting the person, not the particular behaviour or the condition or whatever it is.
Yep. Thank you, Mark.
Thanks for that. I mean, it seems to have opened up a very interesting debate around motivation. I think we are a bit supportive of what Councillor Carter said about, you know, I think we need to maintain the self-referral method obviously, to help. Interestingly, in terms of sort of lifestyle and changing lifestyles, I was reading something yesterday where one thing people are concerned about now is people working from home are putting weight on because they're sort of getting into a more sedentary sort of lifestyle, whereas they used to sort of get up and go to work 5 days a week. They're now sort of sitting at home. I mean, I'm not saying they're not working, but they're doing less physical exercise because it's a lot easier to walk around your house than to get in the car and drive and walk and whatever. So it just seems that that's sort of a way in which society's changed or changing has an impact on this as well. Thanks.
Thank you. Andy, then?
Yeah, I mean, I completely agree. Just to say that the Office of Budgetary Responsibilities did a calculation that sort of 20 billion had been added to the cost to the economy in terms of inactivity and medical costs since the pandemic. So you can cost that. It's absolutely right. And we often talk about this concept of the obesogenic environment. Fancy term basically means the world in which we live just makes it really easy to put on weight, also to be inactive and these things. And yeah, that's only getting worse. So all the more important, from my opinion, that we have these services.
Excellent, thank you. Got Councillor Marianne Overton.
Thought you were going to break into song then. Thank you. Really good discussion, and I just want to pick up 2 points really. One is about the geography of our county, and I see you've got, I think, 19 locations listed in the assessments there, because I think it is really important to try and provide support or encourage people to use the local facilities or somehow share the resources quite widely. And I think you were saying that you're doing that. But I did phone as well, actually, and it would have been an hour and a half driving every session, and there's no point in me doing all that carbon footprint. So I think that's one of the issues, I think, and I hope you're trying to take up just in a way of spreading the services as much as possible would be great. And then just pick up the point about the support for staff as well. I think it is important because we do spend public money on staff. That's what we do. We employ staff. And so, yeah, We are employers and we have a double responsibility there. So I do think, actually, I think it's a good thing where we can see that these benefits are cost effective in terms of the health and the payback, if you like, to put it crudely, from staff, so that you know, certainly the costs of not getting it right are, as been pointed out, very high. So actually, I think from a business point of view, and you know, we're running public services in a business-like way, it does have a substantial payback, and that sets an example for other employers, we hope. On North Kesteven, it was we were just reminded the other day that we are Investors for People Gold Award, which is amazing because that's a lot of effort to get there. And we were just mentioning that this scheme, we did have one of these, and I don't think it's been advertised lately. So it might be that you could get the other districts engaged as well, the other district councils. I think there'd be a significant appetite for being part of that programme. Thank you.
You could on that actually say that what we are doing with our staff is the pilot scheme to learn from that on how we roll it out to other public sectors and to employers, because if we get it right, then actually we can set an example. So, and the other thing is, which you're going to come back on, is the localness. We do have village halls all over the place, and actually I went to one at Saxelby and did a circuit training session, and when I actually counted up the numbers and everyone's paying, not only is everyone there to get fit, they're all having a social, they're all mixing, they're all ages, so there's multiple benefits, and actually the lady that's organising it's actually earning quite a good wage out of it as well. So there's also employment opportunities, and I know if you go to my village it'll be a bit smaller, but there's still a bit of part-time income to be got from sending people running around and doing jump stars and all the other bits. But I'll let you come back on that one, on Marianne's.
Chair, if you don't mind, I won't come back on you jumping jacks or anything, but in terms of the geographical distribution of the service, I think it's a really good point. And one of the reasons we want to extend for the 12 months is ongoing conversations we're having at a system level. And I say that on purpose because we're talking with our NHS colleagues, we're talking with our district council colleagues about how we can broaden out the scope and reach of things like this, given the national push from all political parties to try to help people stay fitter and healthier for longer, and if you have got a pre-existing condition, to try to manage it better. So it's a cross-cutting priority, and the extra 12-month extension here is facilitating that conversation. Clearly, if we want to extend, we're going to need more money. The council's not getting any more money, so we need to find other ways to free that resource up in one way or another, and then build that into the recommissioning process if we're successful. And the extra time here will allow those conversations, hopefully, to come to a positive conclusion over the next month or two, and then build that into the service recommissioning. And of course, scrutiny, you will be fundamentally involved with that bit. And I'll just come back to, this is really helpful, we're capturing lots of notes and we'll build it into next year's model. But for this year, we're not looking to change the existing service model, because of course it's set and we have a contract, and trying to do that in the final year would be quite challenging. But we'll capture all of these points and build them into the service recommissioning model. Obviously, if there's any tweaks we can make this year, we will do.
Yeah, thank you. No, I think there were those three additional things, weren't there, that we're talking about. So yes, I'm supporting the one-year extension, but I'm also supporting those three extensions that you had. Thank you.
Okay, thank you. Got Councillor Sarah Parkin.
Thank you, Chairman. Really interesting report, and I don't think anybody was surprised that it's really encouraging to see is making really good headway. First of all, in terms of the staff issue, for me, that's probably one of the least contentious parts of it, and I would thoroughly support that continuing. A, because I think we do have that responsibility for our own, but B, we are the providers, we are the commissioners of this service, and if we are not as an organisation going to lead from the front and show others what they should be doing in terms of supporting their staff, I don't know who is. So I would beg to differ on that point, but I think it's really important that that is part of our leadership role as we move this forward. My other comment is probably a little bit harder to answer. So I recognise that we're monitoring outcomes, okay? What I'm really interested in, particularly with the families, is do we know where these families are 1, 2, 3, 4 years after the programme? Have we got evidence of that sustained improvement? I know that's an absolute swine of a set of data to try and capture. I understand that. But for me, the magic of this isn't where these families are 6 months, 12 months down the line, but whether this has been a genuine change. And I'm not saying that we don't do it, but I'm saying for me, moving forward for the recommissioning, if we can find a way of capturing that data, that for me is like the holy grail of all of this.
Derek?
It's a really good and really important question. The evidence base around, say, stop smoking would suggest that if you quit at 12 weeks, you often quit at 12 months. So, yeah, exactly. For other lifestyle changes, you do need to embed them. And, you know, the gold standard is you provide support for 12 months. Because generally, from an evidence, from a psychological perspective, if you make a behaviour change that you want to make, but you're supported, you need to maintain that behaviour change for 12 months. And then it becomes, I think it comes back to Councillor Whittington's point about, once you change your behaviour, it becomes your norm, and normalisation is the key point here. Now, with COVID and working from home, normalisation is you don't necessarily, you don't have the active travel bit, even if it's walking to the car or walking to the bus and walking from the car park or the bus stop to work. You've lost that. In terms of this change, it's about normalising it so that if you are working at home, one of the things that from a weight management and exercise perspective you might do is you might increase your walking outside of active travel. If you maintain that over 12 months, it then becomes part of your routine. So I think it's a really good question. It's a really good challenge. We don't have that in the current service model. We did have scrutiny support to fund the University of Lincoln to support the initial evaluation, but that was more of a cross-sectional one. We could look at what it would be if we were to recommit, well, when hopefully we do recommission the service, whether scrutiny's advice at this stage is to get an idea of what it would be to have a 2 or 3 year longer term evaluation with an academic partner that might help answer those questions. Given where the university is and where they're developing their research portfolio, it mightn't be as costly as it would be otherwise, because there's benefits to them to do that as well. And obviously with my academic role, I can do that. So we can look at that and potentially build it into the paper when we come back to scrutiny about recommissioning a service, whoever the provider ends up being.
Did you want to come back? Okay. Councillor Mike Clark.
Thank you, Chairman. I like the report, lots of information, lots of positive steps that we're making. I'm just wondering, obviously money is always the main issue, whether we could persuade the council come another 12 months' time over the budget, or even the NHS, to put more money into these projects, because what would be useful from my point of view, and possibly the general public, would be to see estimates of how much money is saved by this inward investment to start with. Because if we're doing prevention, which everybody says is a good thing to do, are we saving our future services, you know, several £1 million or several million off the NHS? Or are we saving possible deaths, possible long-term medical conditions? So I fully support what's in this, but I do feel we should maybe try and persuade to get more money out of the council in a future budget because of these issues, and also out of the NHS. Thank you.
Thank you.
Really good point again. We are in conversations with wider partners to try to free up additional resource, and the extension will hopefully allow us to conclude those conversations. I can't guarantee where they'll end given the challenges, but certainly that argument is absolutely recognised across the system. As we come back with a new proposal, then we can, there is some, there are national return on investment models that we can apply to this, and we can estimate some of that. Of course, that this will definitely save X is quite difficult, but there's quite a lot of health economics in this area. York do a lot of work on this, so we can build that in and maybe do a short annex for the future paper that says, assuming this sort of activity and these sort of outcomes, we're going to avoid X, Y, and Z, and the total cost to the system, not least to the individuals, would be A, B, and C.
Okay. Just on your overview, are you looking at like the overlap as well between, say, the NHS Links Community Health Service and also the, in effect, locations on offer that between us all? That's all been looked at. The other area of technically does come in this. There's obviously a lot of talk on the television at times about wonder pills and all the other sort of gadgetries, and I suppose as we advance, then that comes into the equation. So when we start looking forward at new contracts, I think there has to be an element that we have to accept that there's going to be new technologies and ways which come in, which we need to adapt in quicker rather than waiting 5 more years to, in effect, wait for the contract to end before we can bring in, if there is a wonder pill coming in, which then leads me into the final bit of pilots. We've got pilots here. Pilots are essential to development, but we need a way in which we can allow a pilot scheme to start up in a contract that can then either, if it's very successful, bolt into that contract rather than waiting 5 years for a contract to end before we can modify it.
If I could come in there, please, Chairman. The pilots that are referenced in the paper have absolutely been integrated into the contract via contract variations. We do have that flexibility to do just that, and that's how these pilots have been brought into this service, and that's how they will then help inform what that needs to be in the future service when we come back here. I think we're scheduled to come back here in October. But in terms of the future model and the future contract, we absolutely are able to put in levels of flexibility in terms of things that may be coming on the horizon or future developments to future-proof that, to give us as much flexibility as we can while signalling to the market what the likely changes or advancements might be. But certainly how we structure those contracts is to give as much flexibility as we can within the boundaries of the regulations that we have to work in. But certainly the variations to the contracts in this contract term have allowed for those pilots, have allowed for all the ones that are in the paper to give us that data to help inform the recommissioning as we go through the process currently.
Excellent. Thank you. Derek?
If I could just put on record my thanks to Rachel and Alina, because this is an area that does move really quickly. The evidence changes. We've got a really good provider who are up for pretty well everything, but we have to make sure what we do is within the rules that govern local government and contracts, and Alina and Rachel have done a fabulous job, and often not short notice but quickly put contract variations in, and we've added new areas, especially as national government have made funding available to us.
Yeah.
To access that funding, we've had to say we can do this and we can do it quite quickly, and that's put a huge amount of work on the commercial team, but they've done a fabulous job of that, and it's meant that we've managed to leverage in extra money, extra resources, and new models that we can pilot for the people of Lincolnshire. So just from my perspective, thanks to that team. Fabulous work.
Brilliant. Thank you very much. Right, I've got Karen and Sarah that want to come back, and then I think we'll wrap it up.
Thanks, Chair. I appreciate you letting me back in. I just wanted to ask Derek about the paper that you mentioned about the costs and benefit analysis. I wonder if we could have that ahead of LCC's budget next year, which is February. Is it possible to get it in time for that? I'm just thinking it's very likely that we're going to have a general election, and it's possible that health funding may be different and local government funding may be different. So we could be in a different I don't think it's going to be that different, but a different financial climate, and it may be that we can, you know, do some extension on this. And I just wondered if we could have that paper ahead of February next year.
I think given our recommissioning timescales anyway, we would want to have done it by then, because we're coming back in October. So probably over the summer we'll be looking at that evidence base. So yeah, absolutely, that would be on the cards regardless.
Okay, Sarah.
Just to kind of reinforce this point about the financial savings potentially from this being right, that makes being able to link it to that evidence of long-term outcomes even more important, because that's where you see the cost effectiveness, isn't it? Is if we can prove that long-term case for change.
Just a quick, I absolutely agree with that. Sometimes we underestimate the short-term return on investment as well. And this was something that we found out with stopping smoking services. As the argument got stronger and stronger about the direct link with smoking and cardiovascular disease and cancers, there was a recognition in national government, and everybody said, well, this is going to save money in 5-10 years. But actually, there was a paper in I think it was the Lancet that demonstrated a cost saving within year, because you were avoiding heart attacks and cardiovascular events and other things within the year that you quit smoking. So sometimes there's actually quite quick benefits as well. Problem we've got is it's cost avoidance, because there's always other things to spend the money on, isn't there, in the system? But if that cost avoidance is somebody not having a heart attack, that's a good thing to avoid.
Yeah, I mean, I just did a quick workout when I was looking at the figures. Basically, 2.7 million divided by about 30,000 people going through one way or another through the service actually came out at about £90 a head. If you took physical exercise out of the equation, it would actually go up to about £180 per person. And actually, I think there is a sense here, isn't there? When anyone subscribes to it, it's not free. It might seem that it's free, but actually the taxpayer is funding you the opportunity up to the tune of about 80, 90 pounds or 180 pounds for this. And actually, that's a saving for anybody, isn't it? You know, and I think we forget that everyone just thinks it's free, but actually it's taxpayer is funding that person to help change their lifestyle. Derek?
Just very quickly, if you see your GP, system costs maybe £30.
Yeah.
If you get admitted to hospital, £3,000, £4,000, £5,000 just for one bed day.
Yeah.
So it doesn't take a lot to demonstrate a cost-efficient service, let alone a return on investment service. And I would say this as Director of Public Health, but within the health and care system, public health interventions are almost always cost-saving, let alone cost-efficient. The vast majority of health interventions are not. That doesn't mean we shouldn't do them. We must do them. But actually, if we want to start that left shift and make our systems more sustainable, we've got to start helping people stay fit and healthy for longer, and if they've got conditions, manage them better, so that we create capacity in our systems.
And actually raising the costs and awareness, like you've just done, £3,000 for a day in the hospital or £30 to go and see a GP. I think people forget those costs. We just think it's free, and actually, but it is actually sometimes what we're doing here is helping to reduce the impact on the cost in the future. Right, on that note, Mark, is it quick?
I was really interested in seeing this paper. I agree with Councillor Lee before the budget setting process. As you're aware, I'm Councillor Hill, support Councillor for Finance. I'm really interested to sort of look at that, because if we have to make a case, we will need evidence to do that. But we do know that other early intervention work we've done in both children's and adults has saved money in the long term. So I think we will need evidence, but more than happy once we've got it to speak with the people concerned, to see what we can do. But we would need evidence. Thanks.
Yeah, it's no good coming with an options list when it's about to go to the executive. It needs to be a bit more sorted out, but that's fair dues, and I think at the end of it we can start to see the shaping up before it comes to us in the future. Alina, welcome.
Councillor Whittington, it will come to CCB, so you will see it at the start of that journey before it feeds through to all the governance, and with yourself sitting on CCB, that would be really helpful.
That's fantastic, Lena, because, as I say, if we can get something that's really evidence-based, then you know, it's a lot easier to make a decision, positive decision, if you've got all the evidence. Thank you.
Yeah.
Okay, so I'll summarise up from everything I've sort of taken notes of. I think that predominantly we're all sort of in support of the extension of the contract, the paper as it is. Any additions? I don't think there's actually many additions that I've picked up on for the immediate contract coming up. The additions I've got to be looked at over the next 12 months when the contract's redone is employers' promotion, businesses looking at the sort of promoting how we can promote it better to businesses and other sector organisations to sort of get their employees healthier. I've got rationalisation of referrals and pathways, which is currently being looked at, and the sort of bolt-on of the sort of pilot schemes, but you're in with all of that. Motivational support, sort of counselling, that was emphasised. The localness of the use of village halls and how we can in effect support that without necessarily getting fully involved in trying to run everything locally, but if there's a mechanism of support. And I think potentially the one that really is out there that is the double benefit one, which is the child and family weight management, which is being added into this year's contract, really wants a big focus, because that not only hits the children but it hits the parents as well. And the final one was about recommissioning, as in terms of the cost benefits and evidence related to that. Karen?
Just one extra, it might be a bit of a cheeky one, just to say that that we as a committee would, how would we say it, be supportive of executive considering the allocations of increased funding to meet the recommendations that we'd need in a future budget, something like that.
I take your point. So in fact, but I would go, so that I've just said, I think would be what I call the next 12 months development, and rolling back to the committee fully supports the 12 months extension. I think the one thing would be in there is, having just mentioned everything else and what Karen's just said, is that the committee is mindful that extra funding could be a very useful asset in supporting the development and focusing on key areas, and there perhaps will be a requirement for extra funding going forward. All in favour? Good, excellent, unanimous. So thank you very much for that. Okay, so now we'll move on to the next item agenda, which is introduction to the Lincolnshire's Carers Service. So for this, we have Anne-Marie Scott, Assistant Direct Prevention and Early Intervention. So welcome, Anne-Marie.
Good morning. Thank you, Chairman. Good morning, everybody. So thank you for the opportunity to bring this outline report to you today around the Lincolnshire Carers Service. And just to set the scene for that, this service relates to unpaid carers in our county. So these are anyone that provides unpaid help to a friend, a family member, someone needing support, perhaps illness, disability. Often we find that carers don't automatically think of themselves as a carer. They might just see that they're simply supporting a friend or a family member who has some needs. And because of that, their role can come on gradually, and often that goes unnoticed by others around them. We know from the latest census that there are just over 70,000 unpaid carers in Lincolnshire, and that's around 10% of our population. The highest proportion of those are to be found to reside in East Lindsey. Unpaid carers make a crucial contribution to society, and also reduce the potential reliance on social care and other formal care provision through their caring role. And we know that although it can be a really rewarding thing to do, it can also be complex and demanding, and inevitably it means that the health and well-being of carers can be compromised as a result. So by intervening early and providing access to information, advice, practical and emotional and support, we can help carers to live a life of their own whilst maintaining their caring responsibilities and a balanced lifestyle. So the importance of the carers' role is reflected in our joint health and wellbeing strategy. Carers is of course one of the 5 priority areas within that strategy. And alongside that, the Council also has a legal obligation to promote the wellbeing of unpaid carers and ensure we've got pathways and services in place to help them sustain that very important role. So in Lincolnshire, to fulfil that responsibility, we commissioned the Lincolnshire Carers Service. This is currently provided by the Serco Customer Services team and Carers First. This provides a single point of contact for new referrals through the LCC Customer Service Centre. It's available to all unpaid carers over the age of 18 and young adults, so that's those from 16 years upwards who are transitioning from the Young Carers service provided by Children's Services. The service includes a number of elements that are detailed in the report, and this is built on a universal offer initially, which is available to all unpaid carers who present with a support need. In most circumstances, this meets their needs quickly and effectively through a range of channels. We also have elements of the service which go on to provide more targeted services that are focused on individual needs. So last year, around 16% of carers who contacted the service and received initial support and information through a conversation went on to receive a formal carers assessment, and this will lead to a targeted support plan for those individuals, and that may include a personal budget for them as well to support them in achieving those outcomes. We've seen particularly improvements to managing finances, having choice and control in their caring role, and time to see their family and friends as particular outcomes that they seek to achieve. When we seek feedback from carers, we're finding that the service is receiving high satisfaction scores. Carers feel listened to, they feel their well-being is being prioritised, and they feel much more informed as a result. In terms of our wider system working with partners, so the Carers Priority Group, which is chaired by Councillor Sneath, aims to deliver the priorities of the health and wellbeing strategy. And that brings together partners from the NHS, Lincolnshire Carers Service, LCC, the voluntary sector, who all work together to deliver a range of outcomes. They could be within their own organisations for their employees, as we recognise there is a large proportion of employees in councils and the NHS who also have a caring role, but also a range of external outcomes supporting carers more widely. So some of the examples you'll see in the report include staff carer networks, of which LCC has a very strong network, support for carers in hospital environments, advice and support for employers so they can maintain carers in their workforce. And we've also importantly utilised a number of co-production opportunities to better understand the experiences and needs of carers. So finally, all of the councils who have an adult social care responsibility are required to carry out a survey of adult carers who are known to the council and have used the services within the last 12 months. The methodology for this and the questions are determined by government guidance, and that's of course so we can compare across areas. And this survey asks questions around carers' quality of life, the impact that services have had on this, and collects information about their general health and well-being. These results are then used to greater understand the needs of carers and support future service development, both locally and nationally as well. So the survey results for last year have only just come in. They haven't been yet fully analysed, and the full national results won't be available until later in 2024. But in the report, we have given a few headlines of what we have seen from those who responded to the survey in Lincolnshire. As you'll see, Most of those that responded were actually retired, and 41% of those spend 100 hours or more a week in their caring role, so a significant proportion of their time. This does interestingly contrast with the census data, which indicates that the majority of the 70,000 plus carers, many of which don't touch our service because they're able to find information and support themselves, actually spend less than 19 hours a week undertaking their caring role. So it really could lead us to suggest that the Lincolnshire Carer Service is targeting the right cohorts, people that are spending a significant proportion of their time in a caring role, and by that very nature are potentially more likely to require additional support to achieve wellbeing outcomes. So that concludes the summary of the report. Happy to answer any questions that members may have. Thank you.
Okay, thank you for that. Martin, you'd like to come in?
Yeah, I just wanted to sort of draw the committee's attention just to a couple of figures that are in the report, just to sort of highlight them, because I think it's very easy to overlook these. So one is the report points out that if the amount of care that is delivered in this county had to be paid for by paid for staff, the figure of £2.4 billion, which is more than the total budget for the NHS and adult social care put together. So the contribution of unpaid carers, if unpaid carers didn't do it, and they don't have to, this is always a voluntary activity, if they didn't do it, it would be devastating on the economy and our society. So our society runs on the unpaid work of carers. And then the other figure that I'd draw the committee's attention to is the fact that 2/3 of those carers are women. And I suspect that if we were to add up, to look at the proportion of hours that are delivered by women, that it would be an even bigger proportion. And so I think it's really important when we're thinking about what support do we provide for unpaid carers. We are essentially talking about a vital service provided voluntarily by women. And I think that sort of helps shape the debate, because it's in a sense, we almost should be talking about women unpaid carers. I mean, yes, there are many men, but it is particularly a female issue. And I think that can shape the way that we need to think about this.
Excellent, thank you. Mark, I've got Andrew.
Thank you, yes. Well, I'll just sort of say, I work in the funeral profession, so I often come into a family's lives after this caring's taken place. So I see the aftermath of the caring, shall we call it, and it is awful sometimes, the pressures these carers have been under, and people that haven't slept for months and months because they've been looking after a partner who perhaps has dementia or something that means they can't sleep. I see the results of what they've done. And so this is such a crucial service, and I commend it, because of the work they do. But, there's always a but, isn't there, in this committee? When we look further in our report pack at our performance measures, the one measure, and this will be coming up later, the one measure we haven't managed to get again is the number of carers supported in the last 12 months, which puts this whole thing at odds with all the good news that this report contains. And I don't want to criticise what's in this report, but it just confuses me a bit that our measure isn't met when this is so important. So I'm sorry to sort of include the two together, but they go together, don't they? Thank you.
No, they do. That's absolutely fair, Councillor Key. So the measure that you've seen in the later report is not just a measure of the Lincolnshire Carer Service. It's of the broader services that are offered to carers, including children's as well. So I think that's the first thing. They're not directly, they don't directly correlate. What we have been doing, and I think the commentary in that report just says that we've recognised that we're not hitting that, and we've done some work with our performance team to understand why that is. And that's also involved looking at the target that we've set and looking at the targets that others across the country have met, And I think it's fair to say that we have set ourselves an incredibly stretched target on that measure. In the report, as you can see, we are up there with others in providing the proportion of support that we do to carers. So it is our intention for the next financial year to review that indicator, make sure that our target is appropriate and that it's something that we can look across with other areas to ensure that our performance can be compared and benchmarked to others. But completely fair question, Councillor Key.
Can I just come back on that? And this isn't meant as a criticism, but the easiest thing to do when you're not meeting a target is to change the target. So I would need to be very convinced before that target's changed that it's the right thing to change the target rather than address the issue, if you know what I mean. Thank you.
Yeah, certainly agree. And one of the things we clearly want to do is look at the service, that the contract measures are being met, that we've set that for that performance element. But also, of course, we do need to look at across our wider nearest neighbours, what sort of service are they providing, so that we can make sure that where we set our target, we're happy in where we're stretching ourselves to.
Okay, thank you. I've got Karen next, then Mark, then Sarah.
Thank you, Chair. I wanted to make some comments, and they truly are not meant as criticisms. I'm just going to tell you about my experience of this, because what I want to know is, it does say on page 16, there's a few lines about how it's advertised. I would actually like much more detail on that, specifics. This is what we do in Lincolnshire. Here are some examples. Appreciate you can't give us every last thing, but I just wonder how this is publicised and how people access it. And again, there's a survey, the response rate, and again, it's no one's fault. The response rate's only 33%, that's a third. And we all know how many people vote in elections. So however hard you try, you know, people don't let you know. But my experience of caring, in 2020, my stepfather died. And my mother had been looking after him for the last couple of years because he had vascular dementia. And it emerged that she'd been really, really struggling. We're quite a close family. We didn't know that. She had not accessed the carers service. She's not an unintelligent, she's dead now. She wasn't an unintelligent woman. If she'd have known it was there, I think she'd have accessed it. So she clearly didn't know it was there. Moving on from that, once Tony died, my stepfather, I got the job of looking after my mum for 2.5 years. And I didn't know that was there. I'm a healthcare professional, so I did know stuff was there. I literally went to Age Concern and got people coming in each day. But any peripheral stuff I knew nothing about. So my question is, how do people know about it? How do they access it? And can you maybe email us after with some good specific examples of this is what we do in Lincolnshire? And I totally agree with Andrew's point. If we're not meeting the target, don't change the target. It's really not a good look. Thank you.
Thank you.
So there's a couple of case studies on the report which gives an individual flavour. And yes, definitely agree, we need to promote the service as much as we possibly can. So at the moment it's promoted through the council's website, through Connect to Support, and importantly through our own adult social care colleagues. So as they are interacting with individuals, they can raise that with them as an opportunity. Through the steering group, which has NHS and other partners on there, that's been a key opportunity to raise that awareness. We've recently opened a carers hub in Boston Pilgrim Hospital. So that's particularly focused on those that are coming to hospital to support somebody so that they can go somewhere and receive that information and advice. We've got links across our other partners in the area, but it's very difficult to find carers. It's very difficult to, we've got 70,000 out there, and we know that the vast majority of them will find information and self-serve, but as you said, we fully appreciate that that isn't the case for everybody.
Can I just come back on it? I mean, I don't want to teach my granny to suck eggs, but it's just things like, I don't know, maybe most people have got someone that goes into their environment, haven't they, who are carers. Perhaps it's looking at those people who, because people won't necessarily go and look for help, but if it comes to them. And I just think if we've only got 33% of people answering that survey, then maybe we need to look at how we're currently doing it. And old people don't go on websites. They just don't. Do you know, that's what I'm trying to say. But I'm not being critical. I'm trying to be helpful rather than critical. I think what we are doing is good, but I think we could publicise it and get to people better.
Hello, and thank you. I'm Lisa Loy, and I am...
Hold on. Can
Sorry.
you just introduce yourself, please?
Yeah.
Because you haven't got a nameplate.
It's Lisa Loy, and I'm the carer service lead in public health, and I've been working on carers for the last 2 years. I think one thing that you've highlighted there is carer identification, and we know nationally that it takes up to 2 years for somebody to identify themselves as a carer because they see it as a part of their responsibility, and they don't actually understand the role, what they're playing, until it actually becomes quite entrenched or at critical level. So the Care Act addressed that and said that we have a duty to make sure that we are positively trying to stop carer breakdown because of all the reasons that we said around the contribution that they make. In terms of looking at, say, for Councillor Sneath, we've invigorated the Carer Delivery Partnership. Is about trying to strengthen that message out to people, to strengthen our employees, because we know that they have they're trying to juggle work and trying to juggle those care responsibilities. So the system is literally trying its very best to try to highlight the importance. And I think that was identified in the Health and Wellbeing Board, understanding that there's still a way to go in terms of making sure carers are a priority for the system. And in my 2 years, I've not met anybody that have said carers aren't important and they're not a priority. I think we have a long way to go. I think maybe what would be really helpful is if we could come and we're trying really hard to get out to people to make sure that continuous, don't forget the carer, hear the voice of the carer. We're doing lots of work, and the investment from the authority is that we do now have a carer's practice lead, so that role kind of never goes away and a continuous part of her role. And we're working really closely with our contracting team to make sure that our measures, so when we talk about the indicators, those indicators are there, but they need strengthening, and that's something that we're actually doing to make sure that we're really assured that what we're delivering is the right, and we've changed that journey. So before, I think it's fair to say that it was a little bit confusing. Where do you go through the front door? We listened to what people were saying. We now have one single front door. As a carer, it doesn't matter who's delivering that service as long as you know where the front door is. And in terms of what you're talking about, the 33% of the survey, that's a national survey. We didn't actually set the boundaries or the metrics within that. So 33% of the chosen 1,200 carers. Now, in terms of what we want to do is those people that do take our service, and I think if we think about the carers' delivery of what we're doing now, it's really important that those 33%, we really do something with that, and it wasn't a tick box exercise. So when we talk about what Anne-Marie said around those people that are providing more than 100 hours of care, it's really important that we use that as an opportunity to make sure we're not playing lip service to it. And so I hope that does give you some reassurance. Maybe one of the things what I would like to see is maybe as an elected member, as a champion carer. And if somebody would like to maybe take that role on, maybe we could.
Can I just say there, Lisa, last Friday after council, we all got these card things about highways and funding and that. Actually, if we had something, because all councillors do surgeries and take leaflets out, we just all do it. If there was a card that says, are you a carer? You can phone this number or speak, or however. I'm sure at some point all councillors could get some of those out for you. Just a thought.
Really good idea.
It is, but I also got a letter from them about a year ago, and I'm thinking, hold on, that's all very well and good, but that's a really expensive way of communicating now. I suspect, actually, if you looked at Nextdoor, the app, what is it, Nextdoor? I think it's Nextdoor is the app. LCC and the NHS and other sectors actually are very good at promoting on that actual app, which is very popular. No, they don't, but it's quite a popular app, and I think, but we'll put that on. That's one of the recommendations is promotion. Right, Councillor Mark Whittington.
Thanks, Mr. Chairman. Yeah, I mean, I think in terms of some numbers, because I've just, I'm obsessed with numbers and stats and things like that. It just comes. So, and the report does say that actually of the 70,000 carers, the number that sort of went to a support group is about 7%. And of those, 798 actually sort of went on to the next stage, which is a formal care assessment. So that's 1.13% of all those carers. So I think that's the kind of the context, I think, behind the question that Councillor Lee was asking in terms of how we make this service, you know, accessible. So, and then Martin, and the report says that you think that it's the cost to the economy, well, the demand of the work unpaid carers do is £2.4 billion. I'd like to see how you've got that figure, because I've just been playing around with my calculator and I think it's 6 billion. And I base it on, and I've based it on just what I can glean from the report. 70,000 unpaid carers, and you said, we know this said that 79% of those live with the person they're caring for. So I've then taken a figure of just over 55,000 carers, which is 79% of 70,000. And I've assumed that they are doing 24/7 care. So 55,300 times 24 times 365 is 484 million care hours per year. And I've just costed that up at £12 per hour, which is just above minimum wage. And I get a figure of 5.8 billion. So I'd be really interested, because, so I think it could actually be higher. And obviously, I'm not an expert in this. I'm just a retired accountant who just plays around with numbers and things like that. So I'd be really interested to see how you've got that figure of 2.4, because I actually think it could be a lot higher than that. And I've only just looked at the 79% who live with their carer, because they're the only hours I can cost. It doesn't include the 21% who may pop in and do other bits. So I'm not saying I'm disagreeing with you, but I'm just saying I think it could be higher, and actually think across the entire country it could be a lot higher. So I'd be really interested to see how that 2.4 billion has been calculated. Thanks, Mr. Chairman.
Yeah, just though on some of this, it's actually there's really promoting the service and making sure the service actually does what people need is really the priority to ensure it reduces, in effect, the burden on adults and NHS. I mean, that's really the three clear, what I call components of a good care service. But validating it takes some doing, and I think we've got to be quite careful that we don't spend a lot of time trying to really validate what the volunteer actual cost saving is. I know I cared for my mother with dementia, but I didn't classify myself as a carer, which is exactly in the category here that we're talking about, and that's all down to one thing. I wasn't going to do personal care for my mother. I would do every other thing, cook a meal, help in the house, reorganise a room after she's reorganised it, etc. But yeah, and I think we have to be quite careful. We can soon get bogged down in trying to sort of make something, and we don't have masses of money like is needed to, in some sense, redevelop. But any views? Can you rejig the figure? Well, as in, are the figures actually validated? Would be the
Yes, and we can provide the formula that sits behind that calculation. It's based on rates that would be paid to care workers if they went in, and the hours that individual carers report that they are working. So we can provide that calculation.
Because I think obviously I've just taken it very rough and ready and just assumed it's 24/7 care. If it's 8 hours per day or 6 hours per day, obviously that affects the formula. I was just sort of assuming that if you are living with somebody 24/7, they might have an emergency at 3 o'clock in the morning, and because you're there, you know what I mean. So it was just very, very rough and ready. But I'm very interested in the formulas and the calculations. As I say, I'm just a wonk when it comes to this sort of stuff. I apologise. It's just. And as Anne-Marie knows, I used to work with her at SK, so you kind of know the sort of, yeah, she's smiling.
okay. Thank you. I've got Sarah.
Coming at it in a similar angle from Councillor Key, really, as another funeral celebrant, bizarrely, like buses, is. Completely agree. I was really interested with the data that most carers don't identify themselves as a carer for up until 2 years, and that's certainly my experience. And I think what it makes me wonder is if they came forward more quickly, if we were more effective in our identification of carers and of people self-identifying as carers, how the hell would we manage the carer service? Because, you know, by what amount would it increase? And how would we ever have the capacity to meet that demand if everybody self-identified earlier? I think we also need to look at and recognise, and I wonder almost if we could record our thanks to carers here in this meeting as a token of the recognition and gratitude that we have for them. But the carers themselves also have a network behind them an awful lot of time of people who are giving unofficial respite and actually negotiating that and supporting that themselves. And my experience is both from work, but in my own sphere, that it tends to be when that network breaks down that the system then, that those networks are so important for those carers. And when that breaks down, that's when we hit the crisis. So I'd like your thoughts on that and how, whether there's anything we can do to get in almost before those crises hit. People saying, I am worried because the person who gives me respite is now going on holiday, or they themselves are now ill, or whatever. And finally, again, it's a similar comment mentioned in health last week, Derek, the impact of bereavement on these carers when they do lose their partner or their spouse is astronomical, because it's not just about the bereavement side of things. It is also a recovery then, almost from the trauma that they may have been through for a considerable number of years. Do we have anything for those carers at that point in terms of signposting them to bereavement counselling, bereavement services? And do we just keep in touch with them? Because we should do.
Thank you. If I'll start, and then Lisa can perhaps add some more detail to that. In terms of demand, yes, fully recognise if 70,000 carers were trying to access our service, that would be difficult. So one of the key things that we do is the information and advice that we provide for carers for them to find themselves, and they can self-serve and do that themselves. The initial conversation that they will have at the front door with an advisor is a strengths-based conversation. So that is very much around what they would like to achieve and how they can achieve that. And I think that reflects in the relatively small numbers that then go on to have a formal carers assessment, because their need has been met from that initial conversation, and they feel confident that they can go ahead and be supported, and they can come back to the service if that changes and they need further support. So that's something that we work quite hard on to do at the front door. In terms of your other two comments, we, as part of the carers service and the in the report, we have something called a carers emergency response. So this is proactive planning with carers for what happens if something goes wrong and someone isn't available, someone becomes ill. What's the backup? And part of of course, we want to support them with that, but it also means that if we can put those plans in place with carers and they can lead us on what they see those are, if the worst does happen and someone isn't able to support, it lessens the likelihood of a call into social care and an emergency situation where the cared for person might need to be taken into care. So we can preempt that happening by supporting them doing that. And we've got a piece of work to refresh that and do some co-production with our carers to look at how effective that is and how we can improve that over the course of this year. So that is a piece of work we have, but we want to improve that. And you mentioned bereavement as well. That is also a key element of the service. So if you stop being a carer, it doesn't mean you can no longer access that service. We've got help for carers who are bereaved and support for former carers to support them through that process. and also, as Derek just mentioned, the Wellbeing Service as well is also a broader universal offer for all individuals from that perspective.
Okay.
So I'll just add just a couple of bits to that. One is around, one of the things that we did know is about, we did sometimes lose carers along the journey, and so now that new remodelling of the service has put lots of metrics in place so we can go back and do a plan with a person, but equally go back and check in and make sure that the support and advice we was giving them is the correct thing to do. So that's been built into the measures within the contract. So in terms of the contract, it's an entirety, will give us much more intelligence and lots of juicy things for us to maybe reflect, work on, and to be able to do things about to be more assured in the future. The other things is around that bereavement. We absolutely know that it is like a trauma, and so with our service provider, we've devised and they're trialling what they call an aftercare programme, so that what we don't want to do is create a dependency, but we want to empower people to be able, and whilst that's almost like a course-like opportunity, it's also going to be reviewed to make sure that what is it that people want and how do we best deliver that to ensure that that person gets the support that they need. And yeah, I think it's just in terms of we recognise that it doesn't just stop, and often the reality is that once that caring ends, that's when it can have the biggest impact, not just on, and then they kind of lose their identity in terms of what role do I play now. So it's really important that we do some work with them on that.
Okay, thank you. I've got Nikki.
Thank you, Chair. Thank you for the report. It's very enlightening, and having been in a situation very similar to, well, very much like what has been reported here, and looking at all of the examples at the end of the report, the thing that I think is probably most important and I would like to put forward to you is the access to respite care. I so needed a rest and sleep when I was doing this, and Martin has quite rightly raised the issues around women doing the work, all of those hours doing around the work, and the work is not particularly easy, particularly if you've got somebody who's a very difficult person to look after, nasty. You do need somewhere to go. So I'd like to know when the dedicated service website is going to be up and running. Also, about bereavement is also about counselling, because self-worth comes into it. If you're looking after a person who doesn't appreciate what you're doing and is very unpleasant, and I've been there, it can be very demeaning, and then you're exhausted. And often the women who are doing this work they're not just doing this work, they've then got a family to look after, and they don't want to dump on their family what they're having to go through. So you try to keep that in. You don't want to share it. So the dedicated website service is absolutely crucial to be able to access respite when you need it, before you hit crisis point really, and knowing where to go to. And also what I want to know as well, of the 798 people who went on to have an assessment, how many of those actually went on then to access financial support? Because it's not easy to access financial support if you're a carer. You have to jump through quite a few hoops actually, and have an interview, and are you doing all the hours, are you doing 39, how do you justify it? There's all of that, and when you're looking after somebody who thinks you should do it for duty, you're then under another pressure. So there's all sorts of things wrapped up in this that I think probably a bit more work on it. But thank you. I mean, the report is excellent. It's highlighting a lot of stuff that we need to look at, and probably in a bit more depth. But those are the things actually I think I would look at first. Thank you very much. Thank you, Chair.
Thank you.
Thank you, yes. So in terms of carer breaks and respite, a carer break doesn't necessarily mean respite. It can be a few hours that the carer can go and do an activity that promotes their well-being, or meet their friends and support for them to be able to do that. And we do link in with adult care separately. Respite isn't part of the Lincolnshire Carer Service itself, but it's something that is linked across to take a view on that and where that's appropriate for that individual. In terms of dedicated service website, this is a branded, recognisable Lincolnshire Carers website. That is in its draft form at the moment. We need to do a little bit more work on that, but please be assured that the information is out there already through the LCC website and the Connect to Support website. This website seeks to really embed the Lincolnshire Carers brand so that it's recognisable, and of course help with promotion and people recognising that as the one front door for them to come to. So the information is there. We just want to make sure it's all very recognisable as a brand. And in terms of personal budgets, so we know in the last year, and this is sort of a rolling year, so it's a slightly different number to the carers budgets accessed, over 800 people received personal budgets, so a large proportion are receiving those. Majority of people do use those for short breaks away and time away, but that can be something as small as having a cleaner come in so that they can support, you know, a few hours for them to help around the home, so it helps them to have a little bit of time to do something else, maybe still in the home. So we've got a large proportion of those that have a formal assessment, virtually all, that go on to receive a personal budget which they can use for their own well-being.
Okay, thank you. Councillor Mark Bowles.
Thank you, Chairman. Yeah, I'd just like to ask a couple of questions really around the potential benefits that could be provided to these carers. As we said, you know, they do it for free, and if they started charging, we'd be in a whole world of mess. So when I say benefits, I mean that in the broadest possible terms. You know, it could be saving money, or it could be, as you've just alluded to, activities and things like that. And just picking up on the point that's just been made about respite, I know as a chief executive of a local football club, we offer free admission to our games for carers. But that's just done locally. That's not in partnership with yourselves or anybody else. So it's about what potential is there for this service to link up with all of the football clubs in Lincolnshire to offer that same, you know, that same opportunity. Like you say, it could be respite for 2-3 hours at a football match. Some of our carers do it and come with the person they're caring for, because before they were ill, they supported the club, so it's an opportunity for both to get out of the house. Again, through our community foundation, we have an adults, a males walking football club that was set up by a gentleman who had cared for his wife who'd had a stroke. He was her main carer. He needed to get out of the house, so he set it up with his friends. So I guess my question is, what can the service do more to link up with local sports organisations, businesses, to try and develop a whole suite and programme of benefits that could be available to these carers? Because you know, I think that would be a massive thing for them. And my second thing is a question for my own knowledge, really. Can I assume that these volunteer carers are not eligible for things like the blue light card that I know my mother-in-law as a carer in a care home gets, and there is quite significant benefits to having one of those? Are volunteer carers not eligible to do that? If not, is that something we could look at locally, working with the local businesses?
Yeah, thank you.
There is, the Lincolnshire Carer Service does connect in the community. I think they've got to refocus on some of their targeted work that they need to do. And because I think in terms of as we evolve, more and more men are coming forward in terms of highlighting the kind of what their needs are, rather than it be, I'm not saying a cup of tea and cake is the right thing, is the right or the wrong thing to do, but for men that's not always the way in which they want that kind of support. So I think that's a really good opportunity, really good, and one that I will make sure we take that back to the Lincolnshire Carer Services to explore. They do have quite a good community ability already, and quite visible. I think in terms of the benefits, there is, so in terms of the carers emergency response plans and signing up to that, there is often benefits so which go out there, which they do get certain discounts, but it's not as established as the blue light scheme or any of those other schemes. But it is something maybe as a system-wide, maybe the carers delivery partnership, if somebody within that group would maybe like to take forward in terms of that recognition. And I think it is quite hard to understand the role what carers play, because, as I say, it takes up to 2 years for people to recognise it. But equally, when you talk to some people, they think carers are people who are home care, who are actually going in and getting paid for it. When you talk about this is family members, this is a friend, this is people who are doing it, So there's still a lot of work to do in terms of that promotion. So.
Okay. Thank you for that. Rob.
Thanks, Chairman. Councillor Lee actually raised the point that I was going to raise about a sort of reference card that either members can have as a reference point, because when I've come across cases of people that I know in my area that could need some help, I've had to sort of do a little bit of research on it, whereas if I had a reference card that either as a member I could use, or as Councillor Lee has suggested, you can give to a resident, because I had to scribble numbers down on a piece of paper and hand it over to the resident in question, whereas if I could give them a properly produced card that also listed the range of services, Chairman, that they can access, I think would be helpful, because it's one thing sort of explaining something to somebody, but if it's actually in black and white, then you can give it to them and say, look, that's what you can get. If you contact this number, they'll advise you. Thanks, Chairman.
Thank you.
Yes, and following on from that, so I didn't write your name down when you said it. Is it Lisa?
Yeah, Lisa Loy.
Lisa, sorry, Lisa. Your suggestion about having a carers champion is, I think, a really good suggestion. Whether it necessarily needs to be an elected member, I'm not sure, because we're here today, gone tomorrow. But, well, we are. But this is a really important job. It's an ongoing job, and I think it's a really, really good idea. So if that could go forward as a suggestion from this committee, I think, like Mr. Bates and the post office, they can make a real difference. It's somebody that people say, yes, they know about carers, you know, they're promoting it. I think that's an excellent idea. Thank you.
I do just think in terms of as well, we can have all the services in the world, but sometimes we know that the people who we know need help and support actually don't engage. So I think it's about having that awareness around there. So, you know, and I know that personally from my own family, my mum and dad don't want people coming in, they don't want that help and support. So I think in terms of as much as we can provide the support, I think sometimes it's about empowering people to have the knowledge so at the right time they can get it. But what we do know is that it usually takes an early crisis point when people can't cope any longer. So I think the more awareness we do, the better, and the statistical information as well around what contribution they make. Thank you.
Thank you. Well, that's the questions sort of from everybody. My part would be, this service now has been running for 10, 12 years. It must have already been now procured. This must be its third procurement through the system. Technically, this is a well-oiled machine now that actually, in terms of a service, this service has been going from the start. It has evolved. In some sense, the numbers actually have been quite predominantly the same. Initially, it sort of had its first initial growth because of, i.e., we launched a service and better promotion. Well, as in more awareness to the residents. So in theory, on reference targets and things, we should be pretty much there, because this service is, as I say, it's not a new service. It is where it is. My question would be is, have we got everything in there that we really need, a wish list, or actually looking to the future? You know, because we can keep rolling it, but it's a bit harder, this service, to put on pilot schemes and sort of other areas to look at. And the other thing which I do know is an impact is the rural area. You know, I know where I lived. I sort of accessed this service when I sort of went with my mother, and I went through everything. And in some sense, I knew what it did. There was in a sense that it wasn't actually necessarily for us at that point in time. But I think it is something that rural areas do struggle because of getting people into them, and especially some of the like befriending services and other things that sort of can happen with it. But I think, is there anything that you feel that actually the service doesn't do and it should do?
Could I come in here, Chairman, please? just to touch on what you've just mentioned around this contract and the iterations of this contract, I was really heavily involved with colleagues in public health in terms of the recommissioning of the current service that we have. And I would say actually it wasn't a like-for-like or role. We actually fundamentally reviewed the model at that point and future-proofed it for the service. So the service now actually looks quite different. The fundamentals of supporting carers hasn't changed, but actually how we have devised that service to have that information, advice and guidance so carers can self-serve, but also identify carers in the community, and absolutely making sure that carers assessments are there and are right for some individuals, but actually encouraging people to be supported by community groups and the information, advice and guidance and the carers conversation piece actually is what carers told us in that engagement for that recommission that they wanted. They didn't want an assessment always, they wanted information. So in terms of how that service was remodelled, it was remodelled based on that approach, and there's always that aspiration for development and continuous improvement as we learn from co-production and some of the other elements that the carer service lead and colleagues in contracting. For me, in terms of the information though, we have got access now through really hard work from colleagues of information around carers that we could have only dreamed of in the last contract, that we will be able to share with colleagues as that information becomes more and more evident throughout this contract. We introduced something called the Carers Lens, and we were looking at information throughout the service from all those angles in terms of information that, like Lisa and Anne-Marie have shared this morning, we wouldn't have been able to give you some of that intelligence around how many hours people are working, that intel around their expectations and their experiences. So I think, yes, this contract, we've come up for the 1 year anniversary, we're about 15 months into this contract, but I think as we progress through this, the information and intelligence to drive things like the Carers Delivery Group, absolutely we have got the right measures in place. In terms of identifying gaps, I think we do that as working across colleagues with service area and feedback from carers. At the moment, the feedback from carers on this service is they are getting a good experience. So it's about looking at the measures we have, which is about outcomes for carers, and those measures are absolutely producing really good outcomes. So I think, yes, we are getting what we need from that service, but we're always looking at how it can change, and the intelligence picture we have with this service will absolutely drive that intelligence through the rest of this contract.
Excellent, thank you. And the final bit really was about promotion. Do you actually, LCC's comms team actually, do you actually access their knowledge and expertise to do it? I just have,
Yeah, there is, in terms of, so we do, it's Carers' Rights Week soon, so I hope to see all of you throughout the county at different venues and different places. We're learning from that. We constantly listen to what people are telling us, and we're in a position to be able to act upon that. So there will be comms, and we have very active comms going out. We also have both our providers, kind of actively promoting it. We've got the Carers Delivery Partnership, so comms, it's still work in progress, but I think we're in a much better position than we've ever been in before, just in terms of the way in which we've got this website, we've got the website which is a draft. We just want carers to be able to find the information, and that's what they're telling us they want. Yeah. They don't necessarily want us sticking our nose in and doing formal assessments, but what they want is to be able to get that support when they need it, and that goes along with the personal budgets as well. They want to have choice and control, and that's what we want to give people.
Good, excellent. Karen?
It's quick, I promise. I take on board what you've said, and it does sound much more positive than it was when I was in that position, so I accept that, and I'm really pleased about that. Just two things. First of all, could we push it at the stand at the Lincolnshire show? A lot of people go to that, the LCC stand. And the second thing, if you email us as councillors, and if you explain what we could do during Carers Week, I'd be happy. But to be honest, I wouldn't know where to start right now. But if you let us know what we could do, then I'd be happy to do something. Thank you.
Yeah, and just remember, Carers Week's 1 week. There's 51 other weeks of the year which can be promoted, and I know the comms team is on the money with the Nextdoor app, so they definitely, you want to be looking at them designing and rolling out some promotion on all of those sort of areas. Right, Mike?
Thank you, Chairman. I just mentioned what you were discussing there about the comms team and using their expertise. I wondered whether we could have a yearly article in our well-worn magazine, which would state then that you know, hang on to this piece of information for future reference.
Yeah, I think actually there was an article done in the county news not that long ago, actually, on it. But yeah. Right, so that was for noting. I take it you've got some interesting feedback and extra knowledge. I've certainly got down promotion, information and advice is really a big requirement and simplified. Respite care would be a bit of an item to sort of look for in the future, but there's various mechanisms for what defines respite care as well. Doesn't just mean a holiday for 2 weeks. Can be like, as Mark said, go to a football match and actually join up with a few people looking on and feeling a bit part of a group, and just people often just want to chat and actually share their issues. And I think sometimes that's actually half of the battle, is the emotional needs. Often, I'm not particularly an emotional type of guy, so it was actually easier to be a bit sort of more stronger with my mother, because she was quite strong with me when I was younger. So, but others would actually would have a real difficulty in walking away from a situation because they are much more emotionally attached. And I think, you know, that's an area that certainly is something where sometimes you've got to just say no. And for some people that's very difficult. Linking in with local businesses and support and carers champion. So, Liz? Hi.
Now on.
It's gone off.
It's something we don't necessarily realise. I hadn't realised how terribly important what we're doing is. Well, I had, but I've gradually come into that. I just want to say I'm working with some really excellent officers, and that's a joy. And I can see, you know, we're doing some really good work, and I'm proud to be part of it.
So,
Thanks very much.
excellent. Thank you. And thank you both very much for coming. So, thank you. Okay, we'll move on to the next item, residential care and residential with nursing care usual costs. Here we have Elena Hackney, Head of Commercial Services, and Pam Clipson, Head of Finance, Adult Care and Community Wellbeing, as the two presenters. So welcome both of you. I'll let you summarise.
Thank you, Chair. Morning, everybody. So if I start, and then Alina's going to pick it up, so it's a bit of a double act.
Can I just do, it's non-pecuniary, but I always feel more comfortable. Can I do a declaration? I'm a trustee with one of the residential homes that would receive payment. So, thank you.
Okay, that's fine.
Okay.
And just for noting that comments to go to the executive.
Yeah. Okay. So as we enter the final year of the current residential framework agreement, the document in front of you is proposing to uplift the rates we pay for care to reflect the percentage increase in the national living wage, which went from 10.42 to 11.44, to the pay elements of the rate structure, and to reflect the forecast average inflation impact across 24-25 to the non-pay elements of the rate structure. Combining these gives an uplift of 7.3% to the rates themselves, which you can see on page 7 in the tables. The financial impact of this is included in the council budget for 24-25 that was agreed last Friday. The structure of the rates themselves feed from the market assessment we completed alongside Lincolnshire and providers as part of the fair cost of care exercise that some of you may remember. Those previous reports and the findings and recommended changes as a result of that are included in section 11 for those who want to go back and have a look at those. We are not proposing any recommended changes to the rates that we've done, and that's as a result of the Market Sustainability and Improvement Grant continuing into 24-25 that was announced as part of the government settlement. You'll see the consultation feedback from the market is included in the appendices for the report. There are 3 key themes to pull out. The first is the view from providers that the national living wage isn't sufficient to enable the sector to compete with other sectors. From our point of view, the rate structure we have is based on the average rate paid by providers. So we have not got a blanket national living wage built into our structures. It is based on the average rate paid, and we uplift that average rate by the percentage uplift change to the national living wage. There is an understandable concern from the market around the volatility in inflation that's been seen by all organisations and individuals, and that it doesn't fall as quickly as is forecast by the Bank of England, which is what we've built into the rate. We will continue to monitor that as finance and into the wider council. However, what we are proposing here in section 3 of the report is to move towards a hardship process. This is a process which will be open to all commissioned providers. We have had it in operation before, and it's where they have the ability to approach the council where they are at risk of closure due to financial loss. It's an open book assessment which is completed between the council and the provider, and it considers the financial viability of the provider, so things like cash flow, reserves that are held, as well as the available capacity across Lincolnshire for the services that they provide, and the position of our capacity and the need of that, and what it would mean for residents should they close. Any financial support provided will be time limited and will be wrapped around with a recovery plan agreed between both the council and the home, so it is not an unlimited approval. And obviously just a reminder there that the council's responsibility is to ensure there is sufficient adult social care provision to meet the need, and that the rate paid for care reflects the cost of that provision. Therefore, that review may conclude that there is sufficient capacity and that no financial support is required. So again, it would not be an automatic, there is support there for everybody. That's changing away from our current or last couple of years, the hardship fund, where we have given dedicated support for fuel, for energy, for insurance, which we've worked with the market upon. So that is a bit of a change from dedicated fund applicable to now a process. And it's actually going back more towards the process we had in before COVID-19. We're going back to that sort of time. The third theme really, and the last one for which I just wanted to highlight for today, I'm going to pass across to Alina, because it's the approach through the contract for third-party top-ups.
Thanks, Pam. As Pam says, this is the third and final year of the contract. Just to give some context, we have 320 homes that we contract for the provision of care and support. 95% of those homes in this county do have a commercial arrangement in place with the council. This contract is subject to consultation, and as Pam's alluded to, there's really two risks that are playing out in respect to that consultation. One, Pam's fed back in terms of the rate itself. The second relates to top-ups. Just to give some context around that, so all providers set their rate. The council pays up to a certain rate. It's called the usual cost. We have many homes that charge the usual cost. It's not over and above that. But where a provider chooses to charge over and above the council's usual rate, that has to be met by a third-party top-up. And the contract sets out how this works. So in relation to the feedback that we've received in respect to top-ups, the accommodation cost automatically rises with an increase in the usual cost. So the differential is always maintained. The contract works to ensure the full value of the council's increase is passed through to the providers by maintaining the value of the top-up in addition to the council's usual cost fee increase. The value of the top-up was fixed at the outset of the contract to protect the families or third parties from significant increases in cost during the contract period, being 3 years. Some providers chose to issue a range of prices. So for every new placement, that top-up may be different dependent on the circumstances. So in relation to the representation that's been made by providers, whilst providers could not foresee what the increases the council would make to the usual cost in respect to the preceding 2 years, they are protected against the uncertainty of the council rates by the fact that their total price automatically rises with an increase in the usual cost. This appropriately balances the impact of risk for providers, families and the councils. And we've entered into a third-party agreement with those families where that applies. Alongside trying to execute this contract with those 320 providers for the 3rd year, we will also now run alongside the review of the commissioning arrangements for all adult frailty and working age adults, so the next generation of that contract, which will run from 2025 to 2028. In preparing for that review consists of looking around the strategy and the demand modelling, but we'll also look at what the contract model will look like going forward. And I'll bring Justin in a few moments to just talk around the approach that we're looking to take in respect to working age adults. That is a step change to how this contract has previously been let. We'll also explore opportunities for joint working with health, so more around the joint commissioning. That really helps providers in turn, so that they're not having multiple contracts with different partners. We'll have the opportunity to review the specification, and our engagement with the sector is really important in that respect. The rate modelling, so the work that Pam's referred to, we have a tried and tested model. There'll be an in-depth review in that respect. We'll also look at the arrangements around third-party top-ups. There was a step change at the last time this contract was let to protect the interests of families. But it was a fair and proportionate approach to providers too. We'll look at the processes, and last time I came to committee last month, we talked about the contract management arrangements in those care settings. We also have the opportunity through this process to work with the sector as to how that will be designed in the future. All of that review will be done in consultation and engaging the sector in that process as well. And we'll likely have forums that will run across the county in respect to that work. But just to conclude, I'm going to bring Justin in now, who will just give you an insight into the work around working age adults in terms of the contract model.
Thanks, Alina. So, yeah, this links really to one of the points that Pam made around market sufficiency. So we set the rates that we would usually play as a council, but providers can choose to sell their services at higher rates. And that, certainly in Lincolnshire, a lot of our residential and nursing care is actually purchased by other local authorities. So some of the market assessments we've done in terms of some sectors of that market can be up to 43% or more of our beds are actually commissioned by other local authorities or other ICBs. So from this point of view, particularly from a working age adult point of view, you know, I want to make sure that we've got enough Lincolnshire care for Lincolnshire people, and that what we don't want to be doing is being in a situation where we've had to got to commission care elsewhere, you know, outside of Lincolnshire and away from, you know, family and loved ones. So, yeah, part of the area is actually looking, particularly where we have got consolidated use with a number of providers, whether we can look at new contract models. So, you know, similar to block and volume. So, if we were, for example, commissioning, I don't know, 20 of 30 beds in a particular residential home, you could probably offer the provider certainty around 15 of those beds for a period of time and then pay a different rate for, you know, the other beds. That way, effectively, what we're doing will protect an element of the Lincolnshire market for our use, and it will solve some of the problems around having to go out for mini tenders and stuff like that. Pretty much the current contract model is a big framework, everyone draws off it. So you go to any home and you pay that price from it. So we haven't got much protection around the capacity there. So that's a major piece of work that we need to do. As Lena says, we need to do a lot of modelling on that. We need to do a lot of engagement with families, and we need to do a lot of modelling with the sector itself. But fundamentally, it's making sure that we've got the right sufficiency of services, of the right quality and at the right cost for us going forward. I'm certainly eager as a commissioner as well to seek to return to some of the ways that we used to do business previously, where we look to agree rates for services over a sort of 3-year period rather than having to annually effectively renegotiate those each year, which puts a huge amount of work on commercial colleagues, frontline teams and the sector itself, and it doesn't provide a great deal of certainty to the sector. So now inflation levels are coming down to a more stable level and a more environment. That would be one of the ambitions around looking at these contract models as well. So more certainty for us as commissioners, more certainty for the sector as well, which is good for everyone.
Okay, thank you, Justin. Martin?
Yeah, thanks. If I could pick up just a couple of points from what's been said, just to sort of highlight them for the committee. So one is the point that providers are ultimately the ones that choose to decide how much they're going to charge. So the council can say, this is the rate that we would like to pay. Providers are not obliged to provide the service at that rate. So, because as a committee, as a council, you could be saying, well, 7.3% increase on a £180 million set of contracts, that ends up as a very large amount of money. Couldn't we save a few £1 million by offering 3 or 4%? I mean, after all, inflation is only at 3 and a bit %. And I think it's important to note that this point that providers have a say in this as well. So the council is under a legal obligation that if we feel that someone needs residential care and the council has to pay for it, then we have to offer them, we have to offer choice, and we have to offer someone a place in a home at a price that we will pay. And if that price is more than our usual rate, then we are obliged to pay whatever the higher rate is. We can't say, well, we're only paying that and we ain't paying anything else. I worked previously for a council which for several years had been seeking to reduce the cost, had been holding down the usual rate level in the belief that would save the council money. At the point that I was working there, I had precisely 18 beds in the entire county that I could buy at what was in theory the usual rate. That was out of several thousand beds that I was buying. So I think it's important that we recognise that we have to set rates at levels which are related to the actual cost of delivery, and that we can't simply say, well, we've only got this amount of money, and so that's all we're going to pay. I think the other point I want to highlight is I think one of the real strengths of the approach here in Lincolnshire, that while clearly it is very important to providers for them to have the right rate paid, they need to, there needs to be a connection between how much we pay and how much it costs to deliver the service. It is of perhaps not quite equal, but very significant importance to providers that they know well in advance what that rate is going to be. It's very difficult to run an organisation if you don't know how much you're going to be paid for a service. And I have worked in councils which took the view that we could only start thinking about the rate that we would pay once the council budget had been set. And obviously it was the budget meeting was on Friday of last week, and so I've worked in councils that it would be at that point that the process would start as to what the fee rate would be from the 1st of April. And clearly the process of calculating and consulting on it, it was never possible to work out that rate. Whatever rate was chosen was then backdated to the beginning of April, but it meant that providers were often in a position of having to deliver a service for 2 or 3 months, not knowing how much they were going to get paid for that service. And that, clearly from a business perspective, that is a really difficult position to be in. The process that we have here in Lincolnshire is a very transparent one, so we have been really clear for the last couple of months. This is the rate that we are minded to pay. We've gone through a consultation process, so there's been the opportunity for some flexing in that. But essentially, providers have known, at least since the end of the calendar year last year, probably for a bit longer than that, pretty much what it is that they're going to get paid from the 1st of April. So they've had 3 or 4 months before those new rates come in to be able to plan and say, okay, I can be pretty clear that this is what my level of income is going to be. And for a business, that kind of, and I know a number of members are involved in the commercial sector, for a business, that kind of forewarning can be a really critical thing. So the fact that is the way that we work, that therefore not only are we proposing a rate be set that is a realistic rate, but that providers know well in advance pretty much what it's going to be is very beneficial. And I think that's part of the reason why we have such a very good relationship with the sector here in Lincolnshire, because of the way that we work. And that's entirely down to the way that Alina and Pam and the team work.
Thank you. In some sense, there was the focus, wasn't there, where we had to make sure that actually where we were setting our level wasn't dissimilar in terms of the commercial level, because in effect the people paying the commercial could actually then question, why can't I have that rate down there? That seems to have sort of disappeared off the government's agenda at the minute, I think.
Shall I pick up, and I may call Alina in to give a bit more of the details. So members will recall that the government, with some fanfare a couple of years ago, launched a reform programme for adult social care. One of the key elements of that was that there was going to be a cap on the total amount that people would be required to pay towards their social care. And therefore, that required there to be an accounting for the money that people spent themselves as self-funders, not going through councils when they were buying care. And that highlighted the fact that self-funder charges are normally about 40% higher than the rate that the council pays. And so the government took the view that really, for this process to work, there needed to be an equalisation between the rates that people paid if they were paying for themselves and the rates that councils paid, and that the way by which that needed to be done was by increasing the rates that councils paid. And so every council in the country had to undertake a fair cost of care exercise to work out what the actual cost of care was, and then the government gave some money to support a move towards that fair cost of care. You're right that agenda has gone a bit quiet of late, and that's essentially because the government decided, having looked at the costs that would be involved and the amount of work that would be required to identify and assess and set up a care account for every single person self-funding. And there are many parts of the country where there are, for every person that's funded by the council, there's 1 or 2 people who are self-funding. So it would have led to a more than doubling of the workload of councils in terms of assessing social care. The government took the view that this was perhaps a matter that it would be more sensible to postpone until after the next general election and leave for whoever forms the next government to do. So I can see Alina twitching because she wants to pick up some of the details.
Only to say, really, even prior to that government's appetite to do this work in a certain way, actually Lincolnshire's done that for 10 years. That's exactly the approach that government asked in terms of the fair cost for care. That's a tried and tested process in Lincolnshire. That's been in place for at least 10 years. So as Martin alluded to, we've gone through a process of identifying what a fair rate is and we've done that in consultation with a third party. So we've worked with a number of organisations during that 10 years where, you know, they work with the sector to identify what a fair rate actually is. And the reason we chose to do that was not because of a government mandate, although that we would echo that was the right thing to do, is because it's important that we know what a fair rate is in Lincolnshire so that we can get the services in the right place. What we don't want to be in a position as what Martin explained, where you can't get a bed at a usual rate. Everything is so expensive. And therefore, you know, either councils or third parties having to make that difference up. So I think, you know, for us, that's been the right approach that we've adopted in the 10 years, although the work that Councillor Martha, what you're referring to was absolutely right. That was cemented through that kind of market sustainability work that both Martin and Pam's actually alluded to. It's important that we have a fair rate so we can commission those services and fulfil those statutory duties.
Yeah. Okay, well, thank you for that. I'll open it up. There's two parts in some sense here that's just now, well, been mentioned. One is, in effect, this is an extension for another year and the rates for that year. And then it looks like there's going to be a major revamp in terms of a review of the service for going back to procurement for the future years, a bit like the first agenda item, actually. So we sort of sit there, which in effect, and it was good that you mentioned working across health and looking at the whole sort of model. And I agreed, you know, you have to work with the existing businesses because otherwise we'll have a backlash whichever way we look at it. And of course there could be looking at a whole new future direction in terms of maybe even using Rwanda's spare accommodation facilities, or like a specialist one unit care centre that actually really specialises for the whole of Lincolnshire. I mean, I'm not saying that that's going to happen and we perhaps shouldn't look at it, or we should, but the point is, if you're going to have a look at the game plan going forward, why not open it up and have a look? There's two types of care often needed. One of those is if you have family and immediate people around you, you often want to be back in your home ground being cared for, or as near so that all the family members and friends can access it. And then there's the other type of person that needs care that actually has no immediate family and actually doesn't really matter where they're located as long as that the care meets their needs. So I think there's good conversations, and I would say that perhaps the future agenda perhaps also wants to come back to this committee before it gets to the wire, where you've got a bit more focused and looking at models and everything else. And I think it would be good for the committee to have a discussion in that before it gets too finalised towards, i.e. going to the executive. So I would say that's perhaps in 9 months' time, and I'll leave that one with Simon. So on that note, I'll open it up. I've got Andrew, and then who else wants to speak? Mike?
Yeah, this is just a quick question, because I'm conscious of the time as much as anything, and I need to go to the loo. So I'll ask my question, then I'm going to have to go. It's to do with the staff costs, really, which obviously are the biggest cost, and obviously they've been treated separately with the extra money for the increase in the national living wage. But my question is concerning the real living wage, which one of the responses refers to here. And Martin and I have had a discussion about this already, but it was just really the cost implications for the council if we were to go along that route, because obviously we've mentioned several times today how valuable this personal care is, even in the home, let alone in residential homes, and I couldn't do it. So what would be the cost implications of using the real living wage rather than the national living wage? I think I've got those words the right way round. Thank you.
So I'll start, and then I'm sure Alina or Pam may well want to come in. So just a bit of explanation by way of definitions, because it's easy to get confused between all the livings and the minimums and the like. So there is a minimum wage set by a national government, which is the lowest, the minimum amount of money that someone needs to be paid to work, and that applies to currently people under the age of 23. There is a national living wage, which is again a figure set by the government, which is the minimum that you can pay anyone who is over the age of 23. And then there is the real living wage, which is a figure calculated by an independent organisation called the Real Living Wage Foundation. And they calculate this based on what they think that people actually need to earn in order to have a reasonable quality of life. So the government has announced the national living wage from the 1st of April next year. The real living wage figure runs to a slightly different timescale, so the 2024 figure hasn't yet been announced. But if I look at the 2023 figures, so the current national living wage is £10.42 per hour. The real living wage is £12 exactly per hour, so it's about 15% higher. And doing a very rough calculation, and I can probably feel that Pam behind me, as someone who knows how to do proper calculations, she may cringe slightly, but the rough calculation, we spend £180 million on residential and nursing care as a county. Roughly 2/3 of that goes on staff costs, so call it £120 million. 15% of that, to reflect the difference, would be £18 million. So in theory, and Pam or Alina may correct me, but in theory, if we were across the board to say our base is the real living wage rather than the national living wage, that would increase the costs by about £18 million in Lincolnshire, just for residential and nursing care, and then there would be a similar ripple through in terms of home care and the like. So a very, very significant financial impact. I think it's fair to say that there are significant voices nationally saying that actually that it wouldn't represent that big an increase in cost because adult social care has the highest staff turnover rate of any sector in the entire economy. Something like 1/3 of all care workers will move jobs in any given year, and a large number of them will leave the sector entirely. And the cost to providers of constantly recruiting and training people is really very significant. And of course, the cost of training people is not just the cost of delivering the training, but the fact that they're having to pay the person to attend the training rather than delivering care. And that there are arguments being made that there should be a national living wage for care, which might be at about the real living wage level, on the basis there is a suggestion that actually by reducing the churn in the care workforce, you might actually save a lot of money from the costs of delivery, and therefore that although the workers were being paid more, the total cost to the employer actually was not that much greater. But I mean it's quite a big step to take. But yes, the numbers would be very, very significant indeed. I mean, I don't know whether Pam is going to...
Just to summarise, that was
I'm
18 million, did you say? 18 million.
Yeah, it will be, and my point isn't to correct the mathematics or anything along those lines, because either way round it's a rather large figure. But it's to come back to the point in the paper that we do not apply the blanket national living wage at £11.44. So we took all of the rates paid per hour across our provider base, working with an independent party. So we, as Alina and I, we and LCC didn't see which providers paid what, but we got the average rate back for the care worker, the senior care worker, the activities staff. We got their rotas. So actually, we pay more than national living wage. When you see the models themselves, we are not paying the 11.44. We are paying higher. So again, we can provide all updates should anybody want it. Worst case scenario would be the 18 million if we paid 11.44. But just to reiterate, we don't pay that. We pay the average based on what our providers responded to us with in the market assessment.
Okay. If we're not careful, we'll go down a whole new route. But I think, in some sense, on what you've just said, Do we see a certain style of care home or residential home that in effect pays a higher wage because of its model is different to another one, or its size is different to another one? Is there a sort of a picture that says, you know what, there's a bit of stereotyping going on here, that style is paying less and this one's paying more, how do we get it? And the other area that I know Link has been working with is, how can we stop higher money lost out the system that could be given to higher salaries and wages because of using temporary support workers and everything else, where they're paying a premium, so then people come out of, in effect, working for somebody to come into being a temporary because they get better pay, but then they don't get the working rights, etc. And I know Lincoln's looking at that, but it all comes down to this career pathway. But I think it is valid because it's the one area that basically, you know what, if you are a carer, you do work hard, and actually to sort of not, you know, cost of living today, to go and have a half decent life costs a lot of money, and the carers are sort of a bit short in that sort of salary wage thing. So it is a big part of it, but I think that's for another agenda item, is the whole sort of workforce. Personally, I think this paper actually has reflected on all areas, and actually I think is a very good rate offered, and I think the work's been intense and deep, and I think we've liaised well, and I think it is a good proposition. Anyway, I've got Mike, and then...
Thank you, Chairman. I noticed in reading the report that we've got a monitoring team, and obviously you sometimes pay out hardship funds. In order to help with cash flow with our various contractors, if I remember correctly, do we pay them monthly or quarterly?
Monthly.
Thank you very much for that. And the other slightly obscure comment I'd like to make, if we know a particular care home is going down the pan, have we ever considered actually buying a care home and running it ourselves? Thank you.
Let's you need to roll back the clock a few years, and it's not that far ago we had our own, and I'll think that will, yeah, valid point. But certainly that opens a whole new ball game. It makes my one care centre specialisation a bit different. But any comments, Alina?
We don't need to. Our occupancy, we have quite a healthy number of vacant beds in the county. If anything, the work that we're doing around what that new strategy looks like is really need to look at demand. In order for this to be a sustainable market, we have too many homes. So I don't feel the answer is to take over the running of that home. However, as I alluded to last month when I came to the committee, in terms of those contract management arrangements, we have an intervention programme, and an intervention programme gets sources of intelligence that gives us a real picture of where there might be sustainable issues, whether those are finance or quality. And what we do is work with the sector. There are mentors in the sector that coach and support those providers. But in the longer term, you know, in terms of when you think of the range of services that adult social care now provide, it's not just about a care home. So we do much, much more now in people's homes, different types of services. And on that note, actually, the point that was raised earlier about having a list of all these different types of services, I've taken note of that. We have a service map, so a one-page document. It gives you an overview of all those different services. We'll make sure that committee members get a copy of that, because it'll just give you an insight in terms of the types of services that are available in adult social care and community wellbeing. So, yeah, the work that we're doing, the direction of travel is to make sure we need to really understand what our demand is, to make sure that in what we're commissioning, there isn't an oversupply or an undersupply. Yeah, I mean, we once used to own a number of our homes. That is not the case now, but fortunately, Lincolnshire is in a good place in terms of being able to get a bed.
And I suppose, in effect, the underlying picture is supporting people to stay and keep their own independence at home. And that's really the bottom line. It's the sort of last resort, really. Mark.
Chairman, looking at page 7 at the table, and we've got the current and the proposed figures. Are those weekly costs? Well, they're weekly costs. They're weekly costs, that's fine. And on table 3, is presumably that's an hourly rate. It's an hourly rate, okay, fine. So, obviously, looking at the table 1, so obviously we've got different complexities of care. Because the comment was made that residential care, about 2/3 of the cost was on staffing costs. Did I hear that right? It's about because. So, and is that uniformly 2/3 over all the different levels? Because if you've got a high level of care dependency, I would be assuming there would be more staff time associated with that particular person. So your 2/3 is an average, apportioned across the different complexities. So it might not be exactly 2. Yeah, okay, that's fine, because I was. It's a real thing. That's fine, because I was just about flashing brain, and I'm guessing the same. It's the same for learning disabilities as well, because obviously you've got the 3 bands in there. So then I'm guessing, okay, so that's residential, but I'm guessing then if you're talking about home care, then potentially you're going to have there'll be a different correlation of staff costs, won't there? Because I'd imagine with home care, would I be right in assuming that with home care, the majority of the costs will be staffing costs with travel associated with it? So for home care, maybe we're looking at, what, 90% staffing costs, or a lot?
I think it's 90 to 90. We can provide the models. It's based on the rotas that the providers gave us back. But yes, the home care and the CSL are our majority, 90-95% on staffing.
Yeah, that's what I was thinking. No, fine. It was just to clarify this in my brain, because I'm likely to get a calculator out in a minute and start tapping away. That's fine. Thanks for that. Okay, brilliant. So yes. So thanks for clarifying that, Pam. Thanks a lot. Cheers.
Thank you. I've got no further questions. So, Tracy.
I've been trying to resist to speak specifically from the Harvish point of view, and I'm sorry, it's got to be. So from our centre's point of view, the rise in the wages, that's actually made an increase to our yearly bill of like 150,000 just from that small minimum wage increase, which actually we worked out from a beds booked from your point of view, that we would need that uplift to be £60 a week per charge. So essentially what we can see there is it actually doesn't take account of any other inflationary uplift that is going to happen, which we all know that there's huge amounts. So although I can see from the providers' comments, I think most of the providers think that LCC have offered something really fair, and I think we have. I think with what we've got to work with, I think it is really fair. But I think, there has to be huge recognition of the challenges that they've got, without a doubt, and this uplift isn't going to contribute and go towards actually the true uplift that they've actually got on a day-to-day basis. And it does still concern me that there are going to be problems for providers. I know the hardship fund's there. Will it be big enough? I think is one of my questions, I suppose. But thank you.
Thank you.
I'll only just come back, and obviously it's an average across the sector. The hardship fund has been in place for the last 2 years, and we've had fewer requests against it than we've got the fund in place. So for us, we've not seen a significant departure from the market. In fact, we've seen net zero change in beds. We've based it on the average on what providers have told us. We've offered providers grants during 23-24 in those particularly hard to reach to sectors. Some providers have decided not to take those grants and rather be open book on their costs with the council. So I do believe this is the fairest, most equitable way we can put a rate in for 24-25 without further engagement from the market.
Okay, thank you. Right, well, I suppose the first thing, do we support the paper? And if so, need a proposer. So, Mark proposing, second, Marianne. All in favour? Any absentees or against? No, that's good, thank you. The second thing, any points of anything for the executive? I just think congratulations to all the team that's been involved and all the hard work that's gone on. I think it's been very thorough, in depth, and I think it reflects a fair price under all the circumstances. And the fact that the hardship fund is there as a backup mechanism is also very good news. And then we welcome actually the sort of and I think really, to be honest, it's good that we are going to do this year going forward, a deep dive into making sure that it's fit for purpose. Is there anything we can do, change? And you're basically having a review of the current procurement contract to take us forward to the future. And I think that that's a good piece of work, and everything that you've mentioned. And I think from our point of view, it'd be good to see that before it gets too finalised. Again, it might need some support. You know, it could be there is a bit of an opportunity to invest to save and other areas. And, you know, when you're looking at it, you may as well open it up and just see what can be done and what can't be done. And sometimes have no barriers in the way and see what blue sky thinking actually does do. I think, as you know, at the end of the day, people don't mind change if they end up with a better service. So, any other points, or are we all good with that? Okay, well, thank you very much, all of you, for your hard work and input on that. Just before, actually, I see we've got Julie Davidson in the back there, who's an interim assistant director of adult frailty and long-term conditions, and welcome. And thank you all, and we'll go on to the next agenda item, which is service level performance against the corporate performance framework. I welcome Caroline Jackson, Head of Corporate Performance, and you'll be quite pleased that there has been some debate on the carers bit. That was our sort of question mark one, and other than that, actually, I suppose the best thing to say is Martin really has set and hit the road running and actually getting good scores going all around here. So generally it looks in very good order. So Caroline?
Yeah, absolutely. I'm conscious that we're very short of time, so I'll keep it very short and sweet. But as you say, a really positive picture. Just to say, as per the comments last committee meeting, like for Q2, we have included the numerator and denominator into the commentary, so you can see the actual numbers that are being, of service users or clients, whatever, that are actually involved. So that's an addition to this report.
Can I interrupt you a moment? Could you bring the mic a bit closer? I've got hearing aids, but I'm still a bit deaf.
No problem.
Thank you.
Yes, hopefully that's a bit better. So yeah, really positive picture. Just to point out, 94% of the measures are either exceeding or achieving. The three measures that are exceeding their target are the same measures that were exceeding in Q2, so consistently high performing. There is one measure that has dropped from exceeding to achieving, and that's around the proportion of adults with a learning disability or mental health need in receipt of long-term care who've been reviewed. But again, still a really positive picture around review activity. The other 13 measures that are achieving their target, I think some really positive points to note around the continuing improvement in emergency and urgent deliveries and collections completed on time of community equipment. We've seen that continue to improve as the additional resource has come on board in terms of that area. In terms of reablement, where the outcome was no support or support of a lower level, we have seen that slightly decrease. It is still within the tolerance for the target set, but we normally see an uptick in performance in Q4 if we see a similar performance to last year. I think the other point to note, I think you've already mentioned around obviously the one measure that isn't achieving its target that we've again had many conversations about around carers supported in the last 12 months. And as previously mentioned, you know, this will be reviewed along with all of the measure set for 24-25, and we will bring obviously a revised framework to you. But all in all, as you say, a really positive picture around performance, and I'll leave it there and hand over for any questions.
Excellent, thank you. Andrew?
Yeah, quick, it's not really a question, it's repeating what I said before really about this carers target.
Yeah.
I will need a lot of convincing before I will vote in favour of changing this target, and I'm sure everybody else will as well. So if you do want to change this target, can you please make sure, and I know you will, that there's a really good reason to change it, because it's always the easiest thing to change a target, and I'm really hesitant about agreeing to anything like that. Thank you.
Yeah, and as I mentioned previously, we will be very robust in terms of the rationale that we put forward for any target, whether that's to increase it, decrease it, or it to remain the same. And we'll ensure that that information is brought to you, obviously for consideration, so you won't just get we want to change it to this or whatever. You will get a clear rationale, which will predominantly be around, as I say, service delivery, whether there's any changes to that service delivery, what has that been, looking at benchmarking, looking at whether we're looking to improve, are we you know, standing still, what are all those factors that will potentially affect our performance going forward, and therefore what would be a realistic target and tolerance, but we'll make sure that comes to you.
Excellent, thank you. Martin?
Yeah, if I can just sort of pick up on and build on what Caroline's said. One of the things that really stands out about Lincolnshire when you compare us with other authorities is that we are a very low spender per head of population, and we are, you know, we're not the lowest, but we are, you know, very much towards the bottom of the the 153 authorities. We're probably about sort of 130th lowest spender. And it would be quite possible that might be associated with a poor quality of service. And I think one of the things that I find very reassuring from these performance data that Caroline presents is that actually if you look at the position, and a number of the charts show where we stand in terms of statistical neighbours, Lincolnshire is not out of the pack. We are the number of people served, the quality of service that they get is average or better compared to our statistical neighbours, despite the fact that we are one of the very lowest spenders in the country. And so I think I'd offer that as a reassurance that actually you're getting quite good performance at a very economical rate. And I think the fact that the CQC were very positive when they came last year is an indication of that. Operationally, I think the service, you can be reassured the service is doing things pretty much right. There's always scope for improvement, but I think the performance data, coupled with the very low amount that's spent in comparison with others, I mean, it's a very large amount in cash terms, but it's a small amount comparatively, I think is a reassurance of a well-run service. And I can say that on the basis that most of this data is from a period before I started, so I can't take any credit for it at all. It's the team that's done it.
I think, I mean, that with all of this, it's, the sort of corporate performances and the service level and the KPIs, again, we have to change those at times because actually we are in an ever-evolving world of change, and sometimes it needs to be made sure that they are aligned to what we want to achieve. Sometimes they can work. We have great intentions for them to work one way, and actually they can be a catalyst to work the wrong way or a different direction altogether. But they all need reviewing at times, and but when it comes to reviewing it, as long as the backup and the information and evidence is there.
Yeah, I'm just to reinforce, we don't just obviously want to be reviewing the ones we're not meeting. You know, and it needs to be very clear, doesn't it, that a review is a review, and it's not just because we're not meeting the target. You know, thank you.
But, anyway, at least it's all good news predominantly, and just that one area. But Mike.
Thank you, Chairman. I've got a question on page 24, item PL 65. It's got some figures in there about adult failure, etc., and specialist services. We seem to be about 2,000 people in there that seem to be missing, as it were. Are they not monitored, or are they not due to be reviewed in this period? Could somebody give me an insight into that?
Sorry, can I just confirm which measure? Because I think my pack might have a different page number with all of the additional reports that have come in.
It's item PI 65.
Right.
Yeah, so while Caroline's looking for the indicator, if it's around reviews, it will be on reviewing performance to date. So people are entitled to an annual review each year. So it will be where are we before the end of the financial year. They'll still be the people that haven't yet had their review, but we're anticipating to have those completed by the end of the year.
Right.
I was going to come in around the learning disability reviewing performance as well. The reason why it's still on target, but why it's not as far ahead as it was before, is that we've implemented new strength-based forms on Mosaic, and that's requiring our teams to go back and do a fundamental reassessment of every individual. So actually it's going to improve things even further as part of that. So we're on target, but it has meant a lot more work for the teams.
Okay, thank you very much. On page 27, it mentions... Oh, sorry.
It's okay. Yeah, I was just going to confirm on that measure, it is a cumulative measure, as you'll see from the graphs. So what we're saying is that we are achieving exactly where we were last year, which hopefully then will mean that we'll achieve similarly in quarter 4, which we would be around the 90% mark in terms of people having had a review. It is an odd one. It's an old definition that we've worked to, where you look at the cohort at the beginning of the year and then monitor it throughout the year. We're saying, I think there's a note underneath the graph saying that we'll probably need to have a look at that definition again for 24-25, and again we'll bring that back to you, because actually within a 12-month period, a rolling period, we should be able to look and see anybody who should have had a review, have they had a review or not. So you should be able to have that kind of in-quarter reporting. So this is one where there's some strangeries around the definition that have been reported at national level, and we're going to review that as part of the 24-25. So, but to answer your question, it is cumulative. Those people aren't necessarily missing in action. Hopefully, they will be reviewed by the end of the end of quarter 4, and it's looking like that based on the progression we've seen throughout the year.
Thank you for that.
And if I can just pick up on that, I mean, one of the reasons why I think the definitions are being changed is that if you look at a group of people who are in a care home on the 1st of January, for example, and then look on the 31st of December, whether all of those people have been reviewed, it is the nature of people who live in care homes that many of them will not have made it through the year, and therefore won't have had a review. But you can't review people when they unfortunately no longer need a review, and therefore that we could never reach 100%. And so that definition of target actually is one that is in some ways quite unhelpful. Therefore, Caroline's quite right that it's appropriate that, you know, it's been changed nationally, and it'll be something we'll need to change locally, because it's actually that's not an entirely sensible way of counting people, particularly with that age cohort, that client cohort.
Thank you for that.
Thank you.
Excuse me. The other question I got was on page 28. It mentions hospital discharges. We seem to repeat a number of times on the television that, you know, people are stuck in hospital because they can't go through the system. I wonder if we've managed to get any further progress on that with the NHS in order to discharge people in a timely manner. Thank you.
Just on that, to be fair, is Julie coming in on that? But actually, Lincolnshire was actually good on that in the first place, and I don't think a lot of the press was necessarily really reflective of our situation. I think we were quite good.
I would agree. I think we are very good. What I've inherited as a relative newcomer is a service that works absolutely in heavy partnership with our NHS colleagues. We have a mature relationship with colleagues. I'm leading on the intermediate care work, where we're looking at both improving hospital discharge to improve outcomes for people, but also looking at admission avoidance. But you will hear about that at next committee.
Thank you. Okay.
And I've got one more, if I may, please, Chairman. If I can get to it, it's page 34. I've made a note here about almost succession planning, I've called it. If we've got an individual dealing with a person with a disability, and unfortunately that person dies, or it's another family member, are we giving any sort of support to them after the event? I know that we're supporting them up to and through that period, but obviously if there's a death, how we're managing or not managing that particular angle of our care. Thank you.
The measure is around the proportion of adults with a learning disability who live in their own home with their family. But the council is asking, should that family member die that has a disability, what support are we putting around the family of the person who's passed away that has the physical or learning disability?
It's quite a good question to the carers team, actually, as well.
Yeah, I mean, in terms of, I think I was going to say exactly that. It links back to the carer support offer and the bereavement, doesn't it? So, I mean, if there will be any specific adult social care needs, then we would look at those for an assessment. But equally, as colleagues said earlier, we work closely with a carer service and we could make referrals in there as well. I mean, if there was a specific need for bereavement support around that, there would be a referral for that. But I think it's a good question, something we should look at further.
Okay. Well, Karen.
Thanks, Chair. Thanks for indulging me, because I wasn't here at the beginning of this item. I just wanted to reinforce what Julie had said about the hospital discharges. Obviously, I've been in nursing for 20 years, and I would say over the last few years, it has improved, the social aspect, that you know, getting them, whether that's to a care home or whether it's the wellbeing service or any of those sort of things. The challenge, and this is the bit that people don't see, is the fact that hospital staffing is absolutely dire. We don't have enough pharmacists, and when a person goes home, they can often they need tablets that are labelled with their names on. You can't just give them anything out of a cupboard. Try getting those from pharmacy. It takes hours because there aren't enough pharmacists, and on top of that, there aren't enough doctors. I don't know why they call them junior doctors, because they're anything but junior. They take huge responsibility, but there aren't enough of them on. And during the week, it's quite challenging getting discharge paperwork done because the ward doctors are doing a big ward round. But then at the weekend, you've got a junior doctor that's taken quite a number of wards, and actually to be writing out discharge documents to enable patients to go home, again, is really difficult. It's just one more job on that person's list. So sometimes the pressures on getting people home aren't always what they seem. But I would agree that the social aspect has improved, especially over the last year or two particularly. Thank you.
Thank you. Marianne?
Thanks. I'm not going to go on that one. On 122, the request for support for new clients aged 65 plus where the outcome was no support or a lower level. And we've got a good, inverted commas, score here where we have a very high proportion, 93%, who ask for help and don't get it. Now, the explanation here is because they don't need it and because we do a reablement. But I can't tell that from this. Is it that, or is it that we have a very high threshold before we offer help? Is there some way in which we can give some evidence that it's not that they went away with an unmet need? Thank you.
Okay, I'll let Martin cover that one off.
So this is a very standard. This is a quality check measure. So it's very standard right across the country that the large majority of people who contact adult social care for support, when given information, advice, and guidance, are then that is sufficient to deal with their issue at that time. A proportion will go through, but the very large majority they'll be able to address their issue with information, advice, and guidance. This measure is designed to make sure are we not picking up people who really do need care. And so what the measure here, and it's a standard measure across the whole country, is that measure of, well, if someone has a genuine need and we've given them information, advice and guidance but haven't taken them into the care system, clearly that genuine need won't go away, and they won't, it's pretty certain that during the course of the next 12 months that need will get worse, or it'll be such that they can't cope, and therefore we measure how many people come back within a year. So they've contacted us, we've given them information, advice and guidance, they've gone away. How many come back within a year because actually the need is such that they really can't cope? And so this is a quality check, because the fact that it's a very, very high percentage of people that we give information, advice and guidance to and they don't come back, the indications are that information, advice and guidance was sufficient to enable them to maintain their existing situation. And so it's by no means foolproof, but it is designed as that quality check, because otherwise we could be batting off a much larger proportion of people who actually needed support, and then we'd have a larger percentage of people coming back. So that's the intention behind it at any rate.
93% is, you're telling me, the people who didn't come back. Right, okay. So they got no support and they didn't need any, or they did get support?
They'll have received information, advice and guidance, but they won't have received formal support through the council. So it could be, for instance, that the advice is it looks like there may be an eligible care need, but from what you've told me, you are clearly above the financial threshold, and so the council can't pay for that service. But on our website, you can find a list of care homes that you might, if that was necessary, or a list of home care providers for you to arrange that care yourself. So it's not necessarily they won't get any care, but the advice could be the council can't help you, but here is a way that we can provide you information that you can help yourself.
Yeah, okay, I understand now, thank you. What I am concerned about is that we don't cover up, we don't excuse ourselves or compliment ourselves on not giving care. I mean, if they don't come back, it could be because they understand the rules, as you say, and there's no way they're going to get anything from the council, so there's no point coming back, and they understand that. It doesn't mean there isn't still an unmet need. And that's maybe not, but, and we do now have a different responsibility, a national responsibility for all people who may need support in our community, not just the ones who we're going to pay for. And so I do appreciate that front support of, as you say, signposting. You know, I do appreciate that that's helpful, absolutely. But I don't want us to think, well, therefore, there's no unmet need, so we don't have to worry anymore. You know, there will still be people who need help, but realising they're not going to get it from the council, so they either suffer and go without, or find some other mechanism, and we'll never know which it was. Yeah, thank you.
All right, well, thank you. Thank you for that, and thank you, Caroline. We will therefore now go to agenda for the work programme. Simon.
Thank you, Chairman. If I could ask members of the committee to just look at the forward programme, particularly a couple of things to, one correction effectively, first on page 45. There are two items listed there which are follow-up from the meeting last time in January. They will in fact just be covered by one item, which is going to be presented by Derek Ward. And earlier this morning we had reference to the integrated lifestyle service coming back on the 16th of October, and also there was a suggestion that the residential care contract framework would be something that the committee could look at, but I will check out the best date on that. Yeah. Thank you, Chairman. Nothing else to add.
Okay, thank you. Karen?
It's not actually about the workload itself. Can I just ask, going forward, if it would appear from the way the agenda is progressing during a meeting, if the meeting will go on later than 12:30, can we have a comfort break, please? There was a few of us that had to leave, and it's just thinking ahead, really.
Thank you. No worries. And noted. Okay, thank you all for coming, and have a good journey home. Thank you.
Thank you, and good night.